Well, good morning. I'd like to call the meeting to order. This is Dr. Hernandez. I'm the vice chair of the board. I'm going to pinch hit for our secretary, who is going to join us a bit later, as soon as the air traffic control will allow for that, maybe literally. So with that, I'd like to remind everybody that this meeting is being recorded, and I would ask if we can do roll call. After roll call, we will need to take action to be able to include our colleague Rick Kronig in the meeting, and so we'll do that to make sure we do that correctly. But let's do roll call first.
Good morning. Secretary Dr. Mark Galley, Dr. David Carlisle,
Present.
Dr. Sandra Hernandez,
Present.
Richard Kronig,
Present.
Richard.
Ian Lewis,
Present.
Elizabeth Mitchell,
Present.
Dr. Richard Pan,
Present.
Don Molds, 6 present, 2 absent.
Great. So with that, we will establish quorum. Richard Kronig, our colleague on the board, informed staff in a timely manner that he would attend remotely, and staff have publicly noticed his intent to appear remotely today. Pursuant to SB 544, Dr. Kronig relayed that due to recent physical injuries, travel would be sufficiently difficult, and therefore he seeks to participate in our HCI meeting via Teams today. Staff has confirmed that he's met all the requirements under SB 544, which is basically an accommodation, that those have been met. And Dr. Kronig is aware of the requirements that are placed on him in order to participate by SB 554, and he will follow them. Dr. Kronig, do you have anything you'd like to add to this?
Only thank you for accommodating these difficulties.
We wish you the best, Richard. Okay, so if there are no if there are no additional questions, I'd like to propose a motion and entertain a second. We will take public comment on the item.
I'll move our second. If you moved, I'll second that.
Okay, Dr. Pan, thank you. Let's take public testimony. Anybody in the room or on the line would like to testify on this item? I see none in the room. Nobody on the phone? Okay, if there's no public comment, let's take a vote.
Secretary Dr. Mark Galley, Dr. Dave Carlisle,
Aye.
Dr. Sandra Hernandez,
Aye.
Richard Kronig,
Aye.
Ian Lewis,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell,
Aye.
Dr. Richard Pan,
Aye.
Don Molds.
Great, welcome, Richard. Thank you, staff, for accommodating all of that. Okay, let's turn the program over to our director.
Thank you very much, Madam Chair. Good morning, everyone. So I think we're first going to start by looking at the agenda. And so having voted on the spending growth targets, we're now really focusing on our many value performance initiatives. And so we are looking forward to robust discussion about our alternative payment model standards and the primary care definition. I'll note that we're going to take the discussion on APMs out of order to discuss before the action item. So we'll be doing item 5A, update on draft alternative payment model standards and adoption goals, including the summary of the advisory committee feedback before we do action 4B, which is to establish the alternative payment model standards and adoption goal. I will also note that we are postponing the discussion on the cost and market impact review draft regulation revisions, and information will be forthcoming on next steps on those CMIR proposed regulation revisions. So moving on to our executive updates, I'd like to start by noting that we're very pleased that Assembly Speaker Rivas has reappointed Ian Lewis to this board for an additional 4-year term, and congratulations. The news broke minutes after the end of our last board meeting, so had to wait till today to make that announcement. So we're pleased that you'll be continuing to serve. Thank you. As you likely know, earlier this month, the governor released the May revision to the 2024-25 state budget. And there's now a projected $45 billion shortfall, $17 billion of which was addressed in early action, but this still does represent a significant increase in projected deficit from the January projection. The legislature is actively discussing the proposal, as is always the case. This is a very hard budget with difficult decisions, and we as an administration will continue to maintain our focus on our values and ideals that we've held past the last 5.5 years, and see where we get in terms of a final budget that is due by June 30th, June 15th to start July 1st. On the next slide, I'd like to highlight HCI's hospital fare billing program. So since the start of this board meeting last year, we've heard from many members of the public who've shared their personal stories about how they and their family members have been impacted by hospital and other medical bills. And every time we hear one of those folks, as someone who worked as a health consumer advocate for a couple of decades, I think, do they know what resources are available to them? So we just wanted to spend a few moments talking about one program that we run here at HCI, because sometimes people are unfortunately just stuck with a high bill because of a high deductible or because of the benefit design of their health plan, and sometimes the hospital or other entity hasn't followed the law, and so want to make sure that we're using this opportunity to make sure folks are aware of this resource. Again, in 2022, the California Hospital Fare Pricing Act, which has been in effect since 2006, expanded to include increased notice and reporting requirements. And there's a new patient complaint process that we're administering here at HCI. There are also new authorization of assessment of administrative penalties against hospitals for violations of the Hospital Fare Pricing Act. So want to remind members of the audience that hospital patients are eligible to apply for a hospital's discount payment or charity care program before or after receiving after they receive services. If they are uninsured, so if they're paying themselves, or if they have high medical costs, and the family income is not more than 400% of the federal poverty level. So this is very important for uninsured consumers. And when we, originally adopted this act, there were many more uninsured consumers, but also if you are underinsured and have high hospital costs and family income is not more than 400% of the federal poverty level, which is also the level at which Covered California subsidies stop, you are eligible for a hospital's discount policy. So since January 1st of this year, HCI has had the authority to review patient complaints for compliance with the Hospital Fare Pricing Act. So we have this complaint program to investigate patient complaints about hospital financial aid eligibility determinations, making sure hospitals are providing patients with required notices about available discount payment and charity care programs. Also, hospitals have to post this notice on hospital walls. And they have to follow proper procedures before sending medical debt to collections, which is a very important protection for consumers. There are also language access requirements, specific notice requirements, and processes. So our hospital bill complaint program is live. Since its launch in January, we've had 73 patient complaints, and we have had approximately $316,000 in patient debt relieved. So if you or anyone you know believe you were wrongly denied financial assistance, you can file a complaint, and HCI's hospital fare billing program will investigate. So for more information, now I'm going to sound like an ad. For more information or to file a complaint, please visit hospitalcomplaintprogram.hci.ca.gov. We also do have some flyers in the room about the program in both English and Spanish, and we've posted it with today's materials on our website. There are also other programs, and I or several other folks in the room are happy to talk to you about what resources are available. So with that, I will turn it over to Deputy Director Pagani.
Thank you, Director Landsberg. I'll start with providing a brief update on our progress developing workforce stability standards since last month's meeting. In response to feedback from the board and other public stakeholders, OCA has initiated a work plan to evaluate the feasibility of requiring healthcare entities to submit data on key performance indicators, such as turnover and retention rates. Our analysis will require several months to complete, and we will update the board on our progress in a follow-up presentation this coming fall. In the meantime, we presented our draft workforce stability standards to the advisory committee, which met last week on May 14th. We will use the board and advisory committee feedback as well as public comment, which will be accepted until May 24th to inform our revisions to the workforce stability standards and metrics. We'll present a final set of workforce stability standards and metrics to the board at the June meeting, after which OCA will adopt the final standards. Next, I'd like to remind the board and the public about board accomplishments to date and its work ahead. To date, the board has achieved the following items listed here. The board established a statewide spending target through calendar year 2029. The board has appointed an advisory committee. The board has also provided input on cost and market impact review regulations and provided input on the total healthcare expenditure data collection regulations and data submission guide. I know that it's just kind of 4 bullets summarizing all that, but I know it's quite a lot of content that we did go through with all of you. But just kind of summarizing it in terms of statutory requirements. So in the near and long term, the board will also need to do what's listed here. Where possible, we've inserted general timing for when OCA would like to bring the topic to the board. You know, the first 2 are being discussed in this meeting. So the board will need to meet a statutory deadline of setting a goal for APM adoption by July 1st. This approval could happen this month or in the next meeting. And then the board will also need to approve benchmarks for primary care spending and behavioral health spending. There's no statutory deadline, but we do have a work plan associated with that in terms of aiming for the primary care spending benchmark to occur this summer, the approval by the board. And then behavioral health is an area that doesn't have as much foundational work done in terms of definitions and measurement. So our investment and payment work group will be providing input on that topic, and we hope to bring that to the board in spring of 2025. We'll also discuss the board will also discuss OCA's adoption of a single set of quality and equity measures, and we expect that to happen this spring, or this coming spring. And then the other items are also listed here. There are some dates in statute, but they're further out. So we've listed them here as just kind of more long-term topics for which the board has decision-making authority. So just want to note that at the next meeting, we'll share with the board an updated work plan for the next few months. We've been sharing them on a quarterly basis. We're currently scheduled to have monthly meetings, but we're reassessing that cadence. So this may involve canceling some meetings when there's not an urgent topic to bring to the board, and OCA may also need more time to prepare deliverables for a particular topic. So we'll soon share a revised meeting schedule for the remainder of 2024. And then moving on to the next slide. So I share this at every meeting just to remind the board and members of the public that are listening in about our slide formatting key. So there's different roles for the board and the office. We use a yellow mark arrow in the presentation for areas over which OCA or the office has decision-making authority. It's important for OCA to get stakeholder input, and these public meetings are a good forum for that. For areas where the board has ultimate decision-making authority, we note it with a green arrow. And I'll now turn it back over to the chair.
Great, thank you for those updates. Let me ask if anybody on the board has any questions about any of the executive updates today. Senator Pan, Dr. Pan.
No, thank you. Appreciate the presentation. I know you made some remarks about the cadence. I guess one of the things I just want to maybe raise for consideration is, I know there's a lot of work going on. Staff's working really hard. At least my email stamped for getting this set of slides, there's like 120 some plus slides, was Monday evening. So I hope that perhaps we can get the slides maybe just a little earlier. In fact, I make note that I think we're talking about potentially going to Monterey for a board meeting. We get it the night before we're supposed to travel. I think it's a little challenging. You want us, at least I try to look at them ahead of time and prepare. So if there's a way we can get the slides a little farther in advance, that would be very helpful so that we can, again, I think hopefully have a more thought out discussion. There's a lot of great material. There's a lot of dense material. I know you work very hard to make that happen. So I was hoping that we can get the slides a little farther in advance than essentially we're about 24 hours, day and a half ahead of before.
Yeah, the timing for this meeting, we did send him a little later than usual. We do try to send him at least a few days ahead, so we'll definitely keep that in mind going forward, because we all want to be mindful of your time and want you to be prepared for this meeting.
Thank you.
Dr. Carlo.
I just wanted to congratulate HCI for the hospital bill complaint program. This is a very needed program. I'll share a minor personal story. I recently received medical care, very, very minor type of care, missed a bill, overlooked it. Within probably a week or two after a 30-day window, I got a letter saying, we're going to take you to collections. And I can imagine how many of these letters go out, how frequently. And so I think benefit to the consumer here is going to be really great, and this program is going to be a great addition.
Thank you. Rick, anything you want to ask or comment on with regard to the director's updates? Rick? Okay.
He waved no. Seeing
I'm fine.
Okay, great.
Sorry, took a while to get to the mute button, but I'm good. Thanks, Sandra.
Okay, great. All right, let's then open it up to public comment.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Please line up at the podium. Those attending virtually, please raise your hand. Please keep your comments to 2 minutes or less so that we can hear from as many members of the public as possible. While the board is committed to communication and transparency, members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Beth Capel, excuse me, on behalf of Health Access California, just to thank the board for its action last month on the spending target. That was a major accomplishment for this board to have gotten through that process. And on behalf of the 80% of California households that make less than $146,000 a year, we very much appreciate the action the board took to adopt those targets. And we also commend HCI on taking over administration of the hospital bill complaint program. That's a measure we sponsored some years ago and think remains extremely important. Thank you.
Thank you. Looking virtually, noting for the record, we have an estimated 100 virtual attendees, seeing no hands raised. Looking back to the room, seeing no individuals at the podium, that concludes public comment on this item.
Great. Okay, so let's move on to our action items. We need to approve some minutes. Deputy Director Pagani, anything you want to say?
Yes, we just have the April meeting minutes. The minutes have been distributed and include written public comment since the last meeting.
Great. Any comments from the board?
I'll just move approval on the minutes.
Is there a second?
Second.
Okay. Any discussion from board members? Welcome, Don. Morning. Rick, you're good? Anything you'd like to add? Any changes? Okay, we have a motion and a second. Let's open it up for public comment.
I'll now take public comment on this item. Please step to the podium or raise your hand virtually. Seeing none, that concludes public comment.
Okay, if not, let's call a vote, please.
Dr. Mark Galley, Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez,
Aye.
Richard Kroenig,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
Okay, I think our minutes have been approved. Thank you to the team. That was a tremendous amount of information that we collated from our last meeting. So thank you for that good work. Okay, so Elizabeth, we're going to go now to item 4. Is that you or Michelle? Michelle? Okay.
Before we move into our action items for today, I want to invite our legal counsel, John Paul, to describe the process for motioning and approving action items.
Good morning, Jean-Paul Buchanan, attorney with HCI. The chair will ask a member for a motion. If a member makes a motion and there's a second on the motion, the board may begin to discuss that motion. If there's no second on the motion, there's no discussion on the motion. Once the motion is seconded, if somebody has an amendment, they can propose that amendment. The person who's proposed the initial motion can determine whether that's in the spirit of the initial motion, so they can accept the proposals without having to go through debate on the second set of proposals. Once the board has finished discussing it, the initial or the amended motion will be presented to the public. They can make provide public comment on it like we did last time. And then at the close of that, there can be a vote. If there's a amended motion and that fails, like last time, we'll fall back onto the original motion. Does anybody have any questions?
Is there an official set of parliamentary rules that this body follows?
Yes, Roberts.
Okay, we follow Roberts?
Yeah.
Okay. All right. Thank you.
No problem.
And J. Paul, we did follow Roberts at our last meeting, did we not?
Yes, we did.
Great, okay. Any questions, comments on that item? Okay, super helpful. Thank you, Jim. Paul. Sean?
So that was just an overview of the process should the board take any action items, but we'll move on to the informational item, which is advisory committee membership. So I'll turn it over to Assistant Deputy Director CJ Howard to lead this discussion.
Good morning, everybody. Again, my name is CJ Howard, the Assistant Deputy Director over the Healthcare Spending Targets branch. We're going to run through the advisory committee selection process today and hopefully appoint some new membership as we have some outgoing members and some vacancies to fill. So just to ground us in the timeline, in April, we closed the application window for submissions of interest to the advisory committee. The subcommittee, which was comprised of Richard Pan and Elizabeth Mitchell, reviewed those applications and are
Our stalwart subcommittee of the board. Thank you very much.
reviewed the applications and will be presenting to you a motion to fill some vacancies and a couple of next steps to solicit further applications as there is a newly emerged vacancy on the advisory committee. So if we could go to the next slide. Just reviewing, so we received 50 submissions of interest. This is just some data on the geographic distribution of those 50 submissions of interest that we received. As you can tell, there's quite broad geographic representation around the state of California. Los Angeles obviously being a large county, we got quite a few from Los Angeles, but also Sacramento, Alameda, San Diego, Orange, San Francisco, and a handful of other counties where we received one application from each of those. We go to the next slide. This is just based off in the submissions of interest, their self-identified areas of expertise that the applicants may have indicated. An applicant could indicate one or more areas of expertise. If we go to the next slide. So this slide just shows us the current composition of the advisory committee, which is a total of 27 members. We had 15 people whose terms were ending. 2 people did not reapply. 1 member will not be returning, and there's a newly established vacancy that I believe we were notified of in earlier this month. So we have some suggested follow-up on how to address that particular vacancy in the hospital category. Again, anybody on here who's highlighted in yellow is the individual whose term is ending, and the other individuals who are not highlighted still have 1 year remaining on their term. So we'll be going through this process again, likely next calendar year.
CJ, can you just remind us how the terms were originally designed?
Yeah, so randomly we assigned people to either a 1 year or a 2 year term, and that's why approximately half, it's a little bit more than half, have their terms ending this year. And so anybody who would get appointed or reappointed on a go-forward basis, assuming that we stick with the precedent that was set last year, would be appointed to a 2 year term. And so roughly half of the advisory committee each year would have a term expiring.
Don, use your mic if you would, please. Sure, yeah.
Is the intent that they go away when they're done with their term, or can they be reappointed? They can be reappointed.
They can certainly be reappointed, and as you'll see, most of the individuals whose terms are expiring, we are recommending reappointment of, or the subcommittee is recommending reappointment of.
And I'm assuming that's the case also for the 2 year folks, that it's not just because we have half the people on a 1 year cycle. Yeah, okay. And is there a term limit, or no? Actually, no.
Okay, CJ.
All right. So if we could go to the next slide. So just this is about the newly established vacancy. Yvonne Wagner recently resigned her appointment. She was in the hospital category representing a rural hospital district. Her term would not have ended until June 30th of 2025. The subcommittee recommends opening the application to solicit forms of interest for individuals who bring a hospital perspective with an emphasis on rural hospitals to the advisory committee. We would open that as soon as today, and likely leave it open for 3 to 4 weeks, and then at our next or subsequent board meeting, we could come back with recommendations on how to fill that particular vacancy that's been established, and that would still could be filled prior to the next advisory committee meeting.
CJ, could you just comment on when we open that or we do a call for nominations, how do we do that outreach?
So we have a listserv that we would blast it to, the same listserv that we use to call for applications initially, and then usually through word of mouth. We would spread the word as far and wide as we possibly can.
Okay.
If we go to the next slide. So with the the recommendations, there are 15 members' terms that are ending. The subcommittee recommends appointing 12 members to new terms. So these would be people who would be reappointed. Again, because there were 2 people who did not reapply, and there was 1 person who would be leaving California and is not having residency within California, would not be eligible for appointment to the advisory committee. And then appointing 4 new members. This would be under organized labor, healthcare workers, consumer representatives and advocates, and then academics and researchers. And so this would be a new category, the academics and researchers. We currently don't have anyone on the advisory committee that kind of serves under that archetype. And this in turn would also increase the size of the advisory committee by 1 from 27 to 28. And we would again propose for now leaving a vacant position and soliciting more applications under the hospital category. Because I think visuals can probably explain this better than my voiceover. If we could go to the next slide. This is what the composition of the advisory committee would look like. So there would be a total of 28 members. Everyone who's highlighted in yellow would be reappointed. So they're currently serving on the advisory committee. And the red people that are highlighted in red would be new members. So the new members would be Christina Rodriguez, Marielle Reataza, Katie Bassler, and Stephen Shortell under the academic and researchers, which would be again a new category for the advisory committee. And then again, leaving that one vacancy held open. We could go to the next slide, or you're already on it. So just this is some demographics of the recommended slate. Again, these demographics are based on the new applications that we have received in our first time when we had opened the application submission of interest last year. We did not ask for demographic information in this form or fashion. This is something that we will do on an ongoing basis. So just to give you some insight into the demographics of those that have applied, this is how it breaks down. If we could go to the next slide on further demographics of gender identity. Here's the status of the new people who have applied. So the blanks is the existing membership where we don't have that data. But so for the new members, this is what they have indicated on their application, that for the folks that have been are being recommended for appointment. We go to the next slide. This is the geographic distribution of the recommended slate based off of county of residence. Again, the blanks are for the individuals who are currently serving and have 1 year left on their term. So this again shows that the individuals that we are recommending, there's broad geographic distribution or representation of California. And so if we could go to the next slide. The draft motion that staff and the subcommittee have put forth is to approve the recommended advisory committee membership totaling the 28 individuals. So this includes 1 vacancy, and then appoint the new and reappointed members for a 2-year term. And before I hand it over, I would like to ask Elizabeth or Richard to add any other commentary that you may have on the process or something that I may have hastily glossed over.
Dr. Pan?
Well, thank you so much, CJ, for that presentation. One of the things I want to just also mention is that, first of all, when it came to at the start process, you kind of start like we closed the nominations, but first of all, we did solicit nominations for, I guess, 4 weeks. Yeah, 4 weeks. So when we talk about the vacancy and how long we're soliciting, we're sort of trying to follow the same process, right? The other thing is that I know the staff they reached out to all the existing members and asked them whether they're going to reapply. So and then they are required to reapply. So everyone had to apply. So even the people, we didn't just default. Okay. So yes, we are recommending their reappointment or appointment for new terms, but everybody had to reapply in the process. I think it's important to know. And we also appreciate again staff providing us information about attendance at advisory committee meetings and so forth. So we didn't just, I think we recognize the experience that they brought, having served on the advisory committee for a year. We did not automatically default by saying, oh, of course we'll just read it. We actually had staff provide us information about participation and attendance at advisory committee meetings. So fortunately, I think people who are very eager to participate. So there were no issues there, but we want to be sure that we were also reappointing people who were active participants. So I just want to thank the staff for really providing this kind of analysis and information for our subcommittee to consider, so we can make the proposal to the full board. one thing I just want to mention is that in terms of the vacancy, part of it is again, we didn't receive the resignation letter till after the solicitation process was almost done. So I think we're treating this as, and it's also midterm, so no one would know that it's been open. So that's why we chose not to propose someone to fill right now, but actually open that. There were people who applied who perhaps will reapply, and that's fine. But for that position, that's why that position is, in case anyone's wondering, why is it being, quote, treated a little differently than the others? The other thing I also just want to mention is that I know this board, we talked about academics, so we're proposing an academic position. On the retiree end, we did solicit, but did not really get really a wide breadth of applicants. And so because of, I mean, that part, I have to admit, wasn't that thrilled about increasing the advisory committee anyway, but we do listen to everybody here. And but given the fact that we were not getting lots of nominees that I think would particularly the broad set of nominees for that particular position, even though we saw it, we decided not to move forward to propose someone just on that regard. So I did want to mention that we did consider that, but given the candidates that we're moving forward, and they're all very fine candidates, so I don't want anyone who's looking at that potentially that they weren't. But I think that we felt that in the solicitation and so forth that basically what we're proposing would make the most sense. Thank you.
Thank you. Elizabeth?
Thank you. And I also want to thank the staff. I think this was a thorough process. I can promise you that we did give ample consideration to the applicants and the process. And I think this is a very strong slate, and not because our subcommittee is awesome, but I do want to note that there was almost 100% reapplication. So I think it really is working. And we wanted to really just acknowledge that, there is a learning curve to this. And as Richard noted, we are noting that everyone is attending, contributing, and really took that into consideration for the reappointments. But I think it's quite gratifying that there were so many reappointments, and we were careful not to expand it too much, but we did feel strongly that this additional category would bring new insight and perspective. So I think it's a balanced slate, and I think it will continue to do good work. So strongly support it.
Well, let me, on behalf of the board, appreciate both of you, your thoughtful undertaking of this, as well as staff. Dr. Carlo?
Yes, and CJ, can you speak again to the process for filling the vacated position now and the timeline associated with it? Thank you.
Yeah, so we could open the application as soon as today. We would solicit applications, and so we would blast our listserv, we would make contact as appropriate, and make sure that everybody knew that there was this vacancy to be filled. Leave that the application open for roughly a month, and then we would review the applications, and we could likely appoint the replacement as soon as the July board meeting, ahead of the next advisory committee meeting. So we would still have the full slate by the time the advisory committee meets again in September.
Great. Any other questions or comments from the board? If not, I just wanted to add one comment to Elizabeth, yours, and Dr. Pan's comment, and that has to do with the fact that folks reapplied is also, I think, a testament to the notion that input has been taken into account both by the staff and by the board. I think it's a time-consuming commitment, and so to me, it's just an important part of the public process. I think if people felt like they were coming to give advice and none of it was taken into account, people wouldn't raise their hand to do another shift. So I just want to acknowledge that. I just be curious, and I have no issue with adding research or academics, but is there a process for thinking about other categories, or how did that particular new category come about? I don't know who I'm asking this to, maybe CJ.
Well, I believe in our discussions here, again, that's us collectively we make the decision. There was discussion about an academic position. I think there were many of the board members indicated that they really wanted to have one, so we include that in the solicitation, and also potentially a retiree, and we did include that in the solicitation as well. And again, in the review of the applicants' candidates, we decided that we would we propose a candidate for the academic position, and given again sort of what looking at the balance and so forth, decided that there was not someone to put forward for a retiree position. So that's hence the motion that we're making.
Yeah, I'll thank you for both, because I think I surfaced both the academic position and the retiree position. So thank you for including an academic. The retiree, I think, who put his name in the hat last time retired from retiree association work. And I had talked to.
It's good to know you could do that.
You can do anything you want. That's the beauty of being retired. I had talked to the associations about someone, and I think there wasn't the right mix of sufficient expertise and bandwidth. So, I'm hopeful that next cycle they'll have somebody who fits the bill, because I do think that's an important voice in this, but it certainly does not feel like an effort wasn't made. So thank you for that.
Yeah, thank you, Don. CJ, I really wanted to also appreciate the demographic data that you're now collecting, and recognize we didn't do that at the outset. What's the game plan for, I think it's super valuable, both the regional as well as the demographic data. Any thoughts about how do we voluntarily go back and ask folks? Are we just going to do this on a go forward basis? What you're thinking?
I think on a go forward basis, it'll be in future and subsequent apps.
Great. Okay. Well, again, thank you to Elizabeth and Dr. Pan. We're going to take public comment, I think, on this item. Thank you, CJ. Do you want a motion first?
Yeah, we'll pause.
Yeah, do you want a motion first? Okay.
Okay. Well, I guess we'll move the slate that was presented by CJ Howard to the board for appointment to the advisory committee.
Great.
I'll second.
Great. Okay. We have a motion and a second. We'll take public comment now. Thank you.
Okay, we'll now take public comment. Please step to the podium. Please limit your comments to 2 minutes or less, noting that we do have virtual attendees with their hands raised at the podium. Please go ahead.
I'm Ivana Krajinovic. I'm one of the people that didn't reapply. I felt like I had to get up here and just say that, it wasn't for lack of interest or, moving to DC or something like that. But I really enjoyed my time on the committee. I think it was more feeling that it was important to have other voices also get a chance. And I'm really thrilled that the board recommended and selected Katie Bassler, who's here. From the Monterey teachers, who might be saying something besides me. So I, will continue to be coming to the board meetings because this is an incredibly important process. And I just felt like I needed to say something. So I'm part of that group that was really interested, but stepped back for other reasons. So thank you.
Thank you. Looking virtually, Catherine, you are unmuted. Please go ahead. Catherine, we see your hand raised. We've unmuted you on our end. You might need to unmute on your end. Catherine Sullivan.
Yes, can you hear me now?
Yes, we can. Please go ahead.
Okay, very good. Okay, I'm Dr. Catherine Sullivan. I'm a clinical faculty member from 360 Wellness Solutions in Riverside County, Rancho Mirage area. So I'm in the desert cities. One of the issues that I'm seeing that is a real concern is that as we decide on academic faculty, I think we have to make a distinction between those that are from the academic institutions versus those that are the clinical sites where medical students, dental students, physical therapy students, nursing students actually have practical experiences. We have a severe shortage of clinical sites. And I would like to ask the board, what is your idea about maybe making sure that when we speak about academic appointments, that we consider clinical education sites as well as academic? Thank you.
Thank you. Looking back to the podium, please go ahead.
Good morning, Katie Bassler, Salinas Valley Federation of Teachers, and Ivana beat me up here. I wanted to start by thanking the board for the consideration of my appointment. I want to thank Ivana for her leadership and her work, and I look forward to helping in any way that I can, and thank you again.
Thank you. Looking back virtually, seeing no hands raised, we have about 100 virtual attendees looking to the room. That concludes public comment.
Okay, Mr. Chair, we are just about to take a vote on the appointment of our advisory committee members after the amazing work done by our subcommittee of the board. And so we've had public comment. We just need to take a vote, and then I'll hand it back to you.
All right, Secretary Dr. Mark Galley.
Presuming nothing changed from what I saw. So, yes, aye.
Dr. David Carlisle.
Aye.
Dr. Sandra Hernandez.
Aye.
Richard Koenig.
Aye.
Ian Lewis.
Aye.
Elizabeth Mitchell.
Aye.
Dr. Richard Pan.
Aye.
The ayes have it.
All right. Thank you. And to Elizabeth and Richard, thank you again for the work. And apologies to everyone for can't control the plane travel piece. So sorry to be late. And thank you, Sandra, for stepping in. So we should get to our next agenda item, the alternative payment models.
Great. Good morning, members of the board. Margaret Brandt, Assistant Deputy Director for Health System Performance. So today I'll be reviewing our proposed alternative payment model standards and adoption goals with revisions since we last discussed in the February board meeting. And also joining me this morning is Vinayak Sinha from our consulting team at Friedman Healthcare, who can help answer questions from the board. So during the presentation today, we'll provide background and then provide an overview of our revisions and proposals for the APM standards and adoption goals. And just wanted to start and take a moment to provide just a brief overview of the purpose of alternative payment models and why we are looking to set goals here to expand their adoption and also include standards for how they should be implemented. So alternative payment models, or APMs, as I might refer to them as, align payer and provider payment approaches to encourage high quality, cost efficient care. And they aim to move away from our traditional fee-for-service system, which can motivate providers to do more, and move to a system based that incentivizes providers to provide greater value. And APMs typically seek to improve patient outcomes, equity, quality, safety, affordability through a patient-centered approach that focuses on prevention and population health. And care coordination, data-driven decision-making, and other strategies support providers in achieving these aims. So to meet our legislative requirements, we organize the work for APMs into 3 work streams. So the first work stream is drafting the alternative payment model standards. And these standards aim to serve as best practices to guide healthcare entities in developing contracting terms to promote equitable, high quality, cost efficient care. And the next work stream is defining alternative payment models. So the definitions serve as a framework and descriptions for the criteria that APM arrangements must meet to count towards the APM adoption goals. And the last work stream is developing the goals. So goals to promote meaningful APM adoption to support equitable, high quality, and cost efficient care. So this is an updated timeline for finalizing all our recommendations. So just as a reminder, we've been meeting monthly with the Investment and Payment Work Group, which is our public work group to provide input on alternative payment models, primary care, and behavioral health work streams. since June of 2023. And in February, we shared with the board a previous draft of our standards and adoption goals. And today's revised standards and goals incorporate feedback from that meeting in February, public comment we received in February, and then also additional feedback from the advisory committee and the work group. And we've included approving the APM standards and goals on the agenda today, and if not today, we will come back in June. So as I mentioned on the last slide, I just wanted to share that this is our investment and payment work group that's been meeting since June of last year. And the work group supports 3 of our work streams, so primary care, behavioral health, and APMs. And for alternative payment models, the work group has provided input on the draft standards and implementation guidance, informed the definitions for data collection, and helped craft the APM adoption goal. And work group members have also helped us refine these recommendations as we incorporate advisory committee and board feedback and public comment feedback along the way. So, and I wanted to thank work group members for their extensive input over the past almost year to help shape these recommendations we'll review today. And just a sense of some of the work group discussions that we've had. So, as I noted, we've talked about alternative payment model contracting standards, whether OCA should require alternative payment models to have a link to quality to count towards the goal, what are the various trade-offs of ways to structure the goals, what should we, include in the standards and focus on in the standards, and how to be more specific with our implementation guidance that supports the standards. So, before we review the standards and goals, I wanted to provide a recap of our vision for success and the opportunities for accountability for the standards and goals. So the standards and goals, of course, are only successful if they are used and promoted broadly. So in our first milestone of our vision is for stakeholders to endorse them, to commit to using the standards to guide their contracting efforts, and to work towards the adoption goals. And here I wanted to share that in working with our public purchasers and sibling departments, that Covered California has approved the commercial APM adoption goals that we are recommending and has proposed aligning their APM reporting processes in their 2026 contract with our proposals. CalPERS has also approved the commercial goals as well and has proposed updating their contracts to include working towards these goals. And DHCS has also approved the recommended Medi-Cal APM goals. So really building on this stakeholder endorsement, the next milestone is for the use of the standards to result in greater alignment across APMs, making participation easier for payers and providers, thus increasing APM adoption. And of course, as APM adoption increases, what we're looking for is for performance to improve, leading to higher quality, more equitable, and more affordable care. So these are just wanted to provide an overview of some opportunities for accountability for the standards and goals. So the standards and goals are not directly enforceable, but there are several ways we can promote accountability. So of course, there's transparency through public reporting on the standards and goals by payer type and payer fully integrated delivery system. Of course, through contracting, so working with our public purchasers and payers to include the goals or standards in their contracts. And we'll, as I noted, we've worked closely with our sibling state departments and the public purchasers to promote this, the goals and standards, and promote alignment, and we'll continue that partnership as we implement data collection and reporting. And finally, we could include progress towards the APM adoption goals and standards in performance improvement plans for entities that exceed the spending targets and haven't met the APM adoption goals. This is just a quick example from Oregon about their public reporting process. So they're reporting on APM adoption, which is informed by their value-based care compact, which is somewhat similar or aligned to our alternative payment model standards. So now I'll walk through the standards and the feedback we've received during the advisory committee meetings and public comment and our work group. So I wanted to just share this approach. So this is the approach that we've taken to the standards and implementation guidance that supplements the standards. And the standards are best practices for contract decisions that are common across alternative payment models. And the purpose is not to develop specific contracting terms, but is to develop common language and encourage alignment across APMs for current and future arrangements. And the implementation guidance supplements the standards for specific actions or examples related to each standard. So these are the alternative payment model standards that we released for public comment during the February board meeting. And in a moment, I'll review that public comment as well as advisory committee feedback and work group feedback. And did want to note, as I've mentioned earlier, that these were developed with input from the advisory committee, months of discussion in our work group, and also with input from the sibling state departments. So I won't read through each of these as you've seen them before, but provided them here and on the next slide, and then also the full set of standards and implementation guidance is included in the appendix. So this slide summarizes the public comments we've received on the APM standards. And generally at a high level, the comments demonstrated overarching support for the proposed standards with minor suggestions for specific language changes. Some of those language changes were recommending emphasizing that physicians should be a part of the design, implementation, and evaluation of alternative payment models, recommending more explicitly stating the need to increase primary care resources and reduce administrative burden, and then specifying the types of clinical staff that can provide healthcare teams with resources and services to address social, mental, and behavioral health needs, such as PharmDs and nurses. And finally, the public comment encouraged OCA to include a new standard that provides access to clinical data registries and support teams treating patients with chronic conditions. So in response to these comments, we are not proposing any changes to the standards themselves, and we've incorporated several edits to the implementation guidance. And these additions include guidance to obtain input from providers in the design, implementation, and evaluation of APMs, examples of primary care team members that can support addressing social, medical, and behavioral health needs, and also language regarding clinical registry data to support providers in population health management. And the revisions to the implementation guidance are also detailed in your appendix, indicating the changes that we've made. And then last week, we presented the standards again to the advisory committee and also to our investment and payment work group, who provided some additional feedback that's summarized here. So 2 advisory committee members suggested adding a standard that requires alternative payment models to be actuarially sound. And we appreciate the focus on protecting access by ensuring payers and providers can continue to deliver care. And implementation guidance 5.3 includes a reference to assuming financial risk in a way that protects financial solvency and supports sustainability. And several advisory committee members noted the importance of emphasizing the value of a PCP and consumer relationship and continuity of care. And we very much agree. And in implementation guidance 3.4 highlights that APM arrangements should encourage consumers to choose a primary care team and supports that relationship. Also, implementation guidance 3.1 notes the importance of providing sufficient payments to primary care to support primary care continuity. And then one advisory committee member suggested collecting information on the adoption of the standards and implementation guidance to understand how care delivery and payment is changing. And as I noted earlier, OCA is considering collecting information on the implementation through performance improvement plans. This next slide provides more advisory committee feedback. So several advisory committee members supported the inclusion of technical assistance for small practices to adopt APMs and suggested payers should also provide funding. And one workgroup member noted the need to increase provider readiness to participate in APMs. And we believe Standard 10 and Implementation Guidance 5.1 do reflect these themes. And then also one advisory committee member suggested presentations by the California Quality Collaborative and others who are leading implementation efforts and collaborative efforts to expand APM adoption among PPO plans. And we will, of course, consider opportunities for presentations from stakeholders and other ways to disseminate best practices. And then one advisory committee member noted the importance of meaningful data sharing, supportive benefit design, such as PCP assignment, and other features to support APM adoption in PPO plans. And we agree and feel that these ideas have been incorporated throughout the standards and implementation guidance to support providers in their ability to engage in APMs. And here I just wanted to pause to see if Ian and Dr. Carlisle had anything to add to the summary of advisory committee feedback on the alternative payment model standards.
For my part, I mean, like all the advisory committee meetings, it's well worth listening to the whole recording, but this discussion in particular was quite instructive to me, especially hearing from some of the primary care practices, primarily Medi-Cal population oriented, but the receptivity to alternate payment models, but a really textured discussion about the fear of the downside risk, financial risk, and the concern about the capital costs of administering the system. It was quite informative for me.
And I would echo Ian's comments, and I think, Margarita, you covered pretty much everything that I noted during the meeting. I was especially impressed by the degree of participation and the enthusiasm of the advisory committee members. I can see why so many of them reapplied for appointment.
Ian, can I put you on the spot a bit on your last comment? What in particular struck you about the Medicaid providers, sort of both maybe enthusiasm and apprehension around this?
And again, I don't know enough about Medi-Cal reimbursement as distinct from commercial to understand the nuances, just that the advisory committee members are disproportionately focused on Medi-Cal populations. But one refers to, I think you used the phrase, the rat wheel of fee-for-service and the frustration with running a practice, a sustainable practice that is driven in part by the need to run up service charges or service-based reimbursement. But then the real concern, the anxiety, I think, of the unknown of what it would mean to jump into a capitated model or what have you, especially for smaller practices.
Apologies for this question, but can you explain again the incentive structure that is built into the legislation or regulations encouraging APMs? So what do we do to promote them, essentially, other than identifying key aspects?
So a lot of it is centered on data collection and reporting, so the public transparency aspect. We currently don't have payer-specific performance that's publicly reported on APMs. There is some kind of work from IHA on kind of the risk models at a kind of aggregate market level. So we would be doing something new by having kind of healthcare entity level performance at the payer level. In the slide, a couple slides ago, we did mention opportunities for accountability. So the other ones were if potential to include this in a performance improvement plan. So if that would require a healthcare entity to exceed the target.
So that's where I was going. So if you come in, if you're a regulated entity and you come in 2030 at 3.5%, one of the things that you point to is the fact that you've invested heavily in APMs, and that is a mitigating consideration if they qualify as an APM, or if the activities qualify as an APM.
It could be if that's determined to be a reasonable factor to exceed the target. That those factors still need to be developed and further specified. But yeah, it really depends on the circumstance. There could be some healthcare entity that has a pattern of missing the target, and then they're also not doing well on primary care, not on APM. So then, depending on the circumstance with that healthcare entity, a performance improvement plan could require them to start working on APMs or invest more in primary care.
I think it's a great question. And so we're limited in our enforcement. It's part of why it's so meaningful that Covered California is including it, that you all are considering it, and the Medi-Cal is. And this board will, of course, have input on the enforcement components for review, including APM investment.
Yeah, I guess just a little bit of feedback. One, there's a big difference between sort of standard APM that's been around forever and novel APM, which involves a certain element of experimentation. If you're missing and you're in a bunch of APMs, I'm not sure that is wildly different than missing. If if the APM is capitation, which isn't new, but it might be a reason if you're trying to improve payment and quality. So thinking about how the experimentation piece factors into those conversations, I think is important, because I'm assuming that we're trying to encourage, as part of this, the evolution of the health system.
A helpful comment. Before we go to everyone's questions, Margareta, do you have more that you want to? Could we hold the rest of the discussion unless it's on the advisory committee feedback? It is? Okay. If you have a comment there, otherwise we'll let her. No, it's completely fine. Go ahead, Richard.
Yeah, no, thank you. And I know there's a lot to cover, so I looked at the slides in advance. So one of the things that I note was that several advisory committee members know the importance of the value of continuity. We've talked about it here on the board, right? That's a key component of, by the way, primary care too. So when we talk about primary care standards, I note in the response, we're talking about sufficient payment to promote support and continuity. And to me, that doesn't seem to be a particularly strong response. And in many ways, these measures, I believe, we're applying to plans, right? Are we applying them to plans, or are we going to apply them to provider entities? Because at least the characteristics don't seem to apply. It mainly looks like it's all about plans, and later we're going to touch on that, right? Is that correct?
These are standards to guide contracting efforts between plans and providers.
Okay, so I guess, and I'm curious to know. And by the way, I essentially practice in Medi-Cal, primary care settings. So I know, so I appreciate the discussion at the advisory committee, because sometimes what happens is that you have a plan contracting with an entity that may be capitated, but the entity, in terms of, for all those grunts at the bottom who are actually seeing the patients, the mechanism by which we are recognized financially by the entity may be a RVU generated. I've seen that over and over again. So, you're not generating enough RVUs, i.e. productivity, versus, wait a minute, it's capitated. I don't get a portion of my portion of the capitation is based on how many RVUs I generate, not based on my ability to manage the money well, the capitation well. So was there any discussion about, I mean, people, anxiety about that, was there any discussion about, you know, how many layers down you need to look at, and not, you know, aside from the plan with an entity, is there, you know, there's delegation, there's subcontracting and so forth, how that gets organized? I would know where that came up. And then on the continuity side, was there any discussion about, well, is how, you know, part of the challenge of continuity is not just pay, it's what happens every year. Someone has a new plan, new contract, and you're always bouncing people around. So was there any thought in the advisory committee about how to really address that continuity issue? Like, okay, if you have a primary care person, you have a chronic condition, you get to stay with that primary care doctor and not have to keep switching all the time. Was there any, you know.
Margaret or David will correct me if I'm wrong. I don't recall discussion about the layers down that you described. The other thing I was going to raise that I omitted was there was one comment about the challenge of attribution and patients, a requirement that patients themselves affirmatively disaffiliate with a practice for purposes of attribution, and the challenge that poses when it's connected, when their pay is connected to quality metrics, which to me resonated as a challenge if we're really focused on driving this in the PPO environment, especially where there's the biggest room to grow.
Okay, and so, all right, that's very helpful. The other question I have, and I don't know what came up in the advisory committee, is, you know, we know half the population spends only 3 to 3.5% of the healthcare dollar, right? The top 10% is 2/3, right? One can argue that an APM for someone who otherwise is generally healthy, isn't utilizing a lot, may be helpful, but probably not moving the needle. APM for the people who are in the top 10% or 20%, that's going to move the needle a lot, and they're the ones who have the most needs and so forth. So was there some discussion about, you know, we're going to talk about percentages later, but about a particular focus on that subsegment of patients who would both most benefit, but would also financially? So, you know, we can have a number and it's like across the whole population, but does, you know, is there some discussion about, that's really who I really care about, who has an APM arrangement or not, that the people who actually have the most, you know, most need and most utilization, right? If I average about everybody, I'm kind of like, that gets blurred out, right? So depending on how, so whether it's portion of dollars or portion, was there any discussion about that in the advisory committee?
I didn't
hear
the
technical work group
at the
anything?
advisory committee.
Yeah,
Okay.
not that I recall. Yes.
Okay. Was that a discussion in the work group? I don't know. So.
That wasn't a strong emphasis of our discussion in the work group. And in the work group, there was a lot of discussion and a lot of emphasis on using alternative payment models to focus on prevention and population health management, and using payments to drive and incentivize those activities. So that's reflected and structured in the standards and implementation guidance.
Okay,
I appreciate moving payments upstream to really focus on prevention.
Okay, I certainly appreciate that. I'm a pediatrician. That's what I do most. But I also think that if we're talking, you know, we're really talking about moving the needle. Frankly, I mean, it'd be great if we could have prevented all those things before they happen, but we do have a whole bunch of people who have chronic conditions. Some were preventable, perhaps some a little less preventable, some due to social factors that are outside the control of the healthcare system. But, you know, we probably want to, I don't know whether we should also have a way to focus on what percentage of those folks actually are in an APM type model versus, okay, what percentage of everybody is. I appreciate the prevention part, like, okay, I want to be sure everyone healthy people don't get sick kind of thing. But in terms of the financial, that's where the money is. And if it's like, oh, we got 50%, but they're all the healthy people, I'm like, okay, well, that's nice. Okay, anyway, thanks. I'm sure we'll get into it more.
Just, I appreciate the last point. I think it's worthwhile just understanding APM applied to different groups of different populations, and how it affects spend in those population groups would be interesting to know down the road. And then to the point about the levels of delegation, the 24 model contract in Medicaid was trying to get at some of this. It wasn't just, well, let's look at what the state pays the plan, but all of those levels. And having some transparency on what those arrangements look like, because even though we capitate almost everything, there are arrangements where the providers aren't necessarily being capitated, and those layers go deep in some counties. So it is worth looking at that and following it over time. All right, Margareta.
Just on that exact point, though, I think it's equally important to have that visibility in the commercial contracts, because it's one thing if employers or purchasers are trying to change payment, and if it never gets to the provider, we haven't achieved anything. And so and consistency across Medi-Cal and commercial will be really important for the practices, obviously.
Yeah, and Medicaid did that. We're dipping the toe in this year as the first one, and then over time, hopefully it evolves and we get better at both thinking through the transparency piece, but also what do those arrangements look like, and how much, as the essentially the entity guiding all of that, how much do we get involved in sort of helping promote what I think many of us want to see, but extending that to the commercial space, terrific. Okay, Margareta.
Thank you. And I will note that in the standards and implementation guidance, we do focus on alignment across market types. So supporting that so that APM adoption is easier for providers. So just wanted to share that. So now we'll turn to the revised APM adoption goals. And again, I'll review background and the goal we presented in February to the board, the public comments we've received, and our proposed revisions. So to monitor alternative payment model adoption, OCA plans to collect data using the HCI expanded framework, and that we discussed that in February with you all, and then to crosswalk the expanded framework categories to the HCP land categories. So the expanded framework is something that HCI has developed to collect more detailed data on non-claims payments that can be rolled up into the HCP land categories. And the expanded framework is provided in your appendix, and the HCP land framework is displayed here. Just a few notes here that APM adoption goals in other states and nationally typically focus on those arrangements that increase clinical and financial accountability for patient care. So those generally are considered categories 3 and 4, so shared savings and shared risk arrangements, or capitation or population-based payments. And adoption is typically measured by spend flowing through a contract with an alternative payment model, members attributed to alternative payment models, or providers contracted under an alternative payment model. And just as background, also provide some APM adoption data nationally and in California. So nationally, currently about 41% of payments are in HCP land categories 3 and 4 across all lines of business based on the latest data from HCP land. And we see that APM adoption is lowest in the commercial market and highest in the Medicare Advantage market. And notably from 2021 to 2022, adoption was virtually flat across payer types.
Just a quick question for clarification. This is payment, not people, right?
Yes.
These are claims?
This is percent of payment.
Percent, okay, thank you.
And just quickly, can you remind me when this was published?
I believe it was published in 2023, and it was.
Sorry, I mean the original framework. From the land.
2016,
right.
Updated in 2017.
Thanks.
So for Medicare Advantage, APM adoption in California, here we see high alternative payment model participation in the, according to data from the Integrated Healthcare Association. So of Medicare Advantage beneficiaries, we see that about 94% or more than 600,000 beneficiaries in 2021 were enrolled in a Category 4 a risk arrangement. One thing to note here is that we do not know whether all of these arrangements include a link to quality. So some of these arrangements may be categorized as what HCP land titles as 4N, so arrangements that do not have a link to quality. And And then in this slide, wanted to share commercial APM adoption in California. Again, this is data from the Integrated Healthcare Association, or IHA, and it represents approximately 88% of the commercial fully insured market, or about 12.5 million people. And self-insured data is not included here. So commercial APM adoption in California in 2021 differed greatly between HMO and PPO arrangements. And this data is based on percent of members, and also wanted to note that IHA found similar results when looking at spending under the in APM arrangements. So percent of members and also percent of payments lead to similar data. So for HMO plans, we see very high APM adoption with 99% of members in Category 4 payments. PPO plans had very low APM adoption with only about 16% of members attributed to Category 3 arrangements, or those shared savings or shared risk payments, and none were in Category 4. And when combining the data across the markets, we see about 77% of members were associated with Category 4 arrangements, and then another 3% with Category 3 arrangements. And then the remaining 20% of members were associated with Category 1 or 2 arrangements. Did wanted to note here that about 50% of the total commercial fully insured population is enrolled with Kaiser. So that's about 6.3 to 6.6 million people between 2017 and 2021. Again, I wanted to point out here that this data is based on data from the Integrated Healthcare Association, but we do not know if all of these arrangements include a link to quality. For example, some health plans that participate in the IHA Align, Measure, Perform program removed the opportunity to provide a quality incentive from their contracts. So it's unclear exactly how many of these arrangements include a link to quality. And then did want to note that we also do not have APM adoption data for Medi-Cal. And as I noted earlier, we've been coordinating with DHCS both on total healthcare spending data collection and working with them to develop proposed alternative payment model goals that seem reasonable and achievable for Medi-Cal. Here on this side have commercial PPO APM adoption, so just wanted to dig a little bit deeper. Just note that about 16% in 2021 of members were in Category 3 APMs. And again, with the link to quality, it's unclear whether these arrangements included a link to quality. So as I noted earlier, that we will use the Healthcare Payment Learning and Action Network, HCP LAN framework, to monitor our progress towards increased adoption of APMs, and that we are recommending that the APM adoption goal be based on percent of members attributed to HCP LAN categories 3A through 4C, and those are highlighted in the yellow box. So only members enrolled in those highlighted arrangements would count towards the adoption goal. And then we also wanted to go a little bit deeper and note that we drafted definitions to define what counts towards the APM adoption goal. So the purpose here is really to ensure that APM adoption supports shifts in quality, affordability, and equity, not just increasing provider risk. So to count towards the APM adoption goals, we recommend that APMs include a link to quality and include meaningful risk sharing for those Category 3 arrangements. So for meaningful risk sharing, we are recommending that Category 3A and 3B APMs should be required to meet a minimum threshold for shared savings and shared risk in order to count as an APM. And this requirement ensures that arrangements built on a fee-for-service architecture have tangible financial incentives or penalties that are contingent on the provider's attainment of a predefined spending and quality benchmarks. And these specific requirements are also detailed in the appendix and described in the expanded framework definitions. And then for a link to quality, OCA recommends that including payments to meet the APM adoption goals only if they involve potential for financial bonuses or penalties based on providers' performance against predetermined quality benchmarks. And this would exclude, again, HCP land categories 3N and 4N. And this definition ensures that APM arrangements have a connection between payments and quality outcomes. So these are the proposed goals that we shared with you all in February. They included a 10-year timeline that moved all payers and all payer types to 75% of members in APMs by 2034. And we heard your feedback for a preference for shortening the timeline, also recognizing the differences in starting points for payer types and how this may impact the final goals, and to consider how these goals impact cost drivers in health systems. And then now I'll share the feedback we received via public comment on the APM adoption goals in February. So the public comment generally expressed support for the goals tied to HCP land categories 3 and 4. There was concern that the 10-year timeline, the 10-year 75% goal that was proposed may be overly ambitious and unattainable for commercial PPO or Medi-Cal. There's concern raised that the proposed goals and timeframe oversimplify the significant shift in healthcare delivery system required. Also, recommendation for purposes of APM adoption in Medi-Cal that the goal should be based on a denominator that includes only those non-dually eligible Medi-Cal members. And there's also a recommendation to include details on the definition of the denominator in the total healthcare expenditures data submission guide. So in response to this feedback, we worked with payers, sibling departments, and our work group on the goals and made some adjustments, which I'll share in a few minutes. And these goals aim to reflect the recent discussions in the work group and sibling departments, and then also seek to align timeframes with our proposed primary care investment benchmark. And I'll note that OCA will provide data collection and reporting guidance on the denominator to measure progress towards APM goals in our data submission guide. So we lots of specificity in terms of how reporting will work, and what will be counted towards the APM adoption goals will be covered in our data submission guide. And then before I share the updated goals, I just wanted to share a few more background slides in terms of the work we've done in our work group and with others to try to vet some options for revised goals. So following the February meeting, we took some options back to our work group with potentially a shorter time frame and adjusted goal percentages, and their feedback is included here. So first, payers were concerned about using all members as the denominator for commercial PPO APM adoption, and encouraged OCA to consider only including attributed members. They also mentioned that feasibility for achieving the APM adoption goals depends on how the denominator is defined, and we'll talk more about the challenges of attribution and the denominator in the next slide. And then also, stakeholders varied in their opinions on proposed 5-year goals. So we considered 5-year goals with both higher goals for commercial HMO and Medicare Advantage, and a 40% goal for commercial PPO over 5 years. Some stakeholders thought that this goal was too high and unrealistic, while others supported a higher goal, and others still supported a longer timeline. We also heard concerns raised about self-funded plans meeting the PPO goals. And then finally, in response to a proposed 95% goal for HMO adoption and Medicare Advantage in 5 years, stakeholders suggested lower, more feasible goals and alignment across product types. So in this next slide, we'll review some challenges with common attribution methods used in commercial PPOs, which can contribute to the challenges of APM adoption in PPOs. I'm sure many of you are familiar with this, but wanted to note that OCA plans to include all members in the APM denominator for commercial PPO adoption because it best aligns with population health goals, including the goal to engage those who may be less likely to receive care. So including all members in the denominator is aligned with our APM standards focused on prevention and population health. And then just in terms of the attribution challenges, just wanted to kind of share this is a general approach used by PPOs in terms of applying members to APM arrangements. So when members, all members are in the denominator, members accessing care can be attributed, and then sometimes even members have to access a specific type of care in order to be attributed. And again, not all providers are necessarily able to or positioned to succeed in these types of arrangements. So potentially not all providers participate, and then also not all members are able to be attributed. So in general, this results in lower attribution rate for commercial PPO products. So just given these complexities, these were raised by many of our work group members and have informed our revised goals. And then just wanted to share again one more background slide before we get to the proposed goals. Just because we've received a mix of feedback on the timeline for our APM goals. So some stakeholders have supported a 10-year timeline and others have found it to be too slow. And our goal is really to balance the need for timely, sustainable achievement of APM adoption goals. We want to promote broad participation and meaningful APM arrangements. And we recognize we need to change. There's a change we need to do now, but also want to recognize the time and effort it takes to do care delivery redesign and recontracting. So we are looking to make sure the goals are attainable and promote broad provider participation in APMs.
Margareta, before you go on, was it a question on slide 4?
Yeah, I mean, so you've actually spent several slides and a while talking about the challenges on the PPO, but I sort of feel like before we get into the percentage part, I realize to inform the percentage, perhaps we need to have I have some questions for, again, Chair, you can decide when you want to take them, but to clarify exactly the PPO piece, because I sort of feel like, we can talk about too fast, too slow, whatever, too high, too low, but actually the definition and attribution are going to be important in trying to figure out what is the right number, right? So unless we have so I don't know when we might have that discussion.
Let's include that as part of the broader. I think it's a good place to start, but
Okay.
Let's go ahead, Margareta, get through. I think we're getting towards the end of the goals, presenting them, and then we can open it up and we can start with that.
Thank you. So these are our revised APM adoption goals based on the feedback we received based on discussions with the work group and with payers. So these revised goals set 2-year goals accumulating in a 10-year goal, and these goals differ by payer and product type. And OCA is proposing a final 10-year goal of 95% of members attributed to HCP land categories 3 and 4 for commercial HMO and Medicare Advantage payer types, 75% for Medi-Cal, and 60% for commercial PPO. And just wanted to emphasize that all arrangements to count towards the goal, we are proposing that all arrangements would need a link to quality. This glide path would more than triple commercial PPO members in HCP land categories 3 and 4 from 16% in 2021, and really want to reinforce that we would be publicly reporting on progress on the biannual goals. And then just did want to re-emphasize that we've worked with Cover California, CalPERS, and DHCS to develop and approve these goals. And that we may consider revisions to the APM adoption goals after the first 2 years of data collection, when we have a better baseline of understanding how many APMs have that link to quality and count towards the goal. So we can revisit these goals based on baseline data. And then, so sorry, do have several more slides based on kind of summarizing the feedback we received on the goals, both from the advisory committee and our work group members. So most advisory committee members and work group members raised no objections to the goals, and several expressed support for the revised goals. Several advisory committee members and work group members recognized the challenge of increasing APM adoption in PPOs and noted how this influences the proposed goals. And then one advisory committee member was concerned that the Medi-Cal adoption goals may be too ambitious. And then, just as I noted a few minutes ago, we do appreciate that APM adoption does vary by payer type, and we've revised the goals to reflect this. And that we can also consider revisions to the adoption goals after 2 years of baseline data collection. And then in terms of several advisory committee members also suggested collecting data from provider organizations. So getting to one of your questions earlier, to understand APM adoption at the provider organization level and how provider organizations pay downstream providers. So our initial data collection and accountability will be at the payer level, and OCA is planning to collect data from provider organizations with restricted or limited Knox-Keene licenses in the future, and we have not determined whether we'll collect data from other entities. So we can get to APM adoption by restricted and limited Knox-Keene licenses. And then just again, wanted to pause here to see if Dr. Kyle or Ian had anything to share on this summary.
You've covered all the discussion that I recall.
Okay. So just in terms of what we can report, so just wanted to share a few a few reporting options to promote transparency and to inform our future work. So through our reporting structure, we can look at the % of members attributed to APMs, which is the proposed basis for our goals. We could look at the % of dollars paid via APMs. We could look at the % of dollars paid via non-claims generally, dollars paid via facility capitation or other types of capitation, and then also look at spending in infrastructure and practice transformation supports, or spending in episodes and bundles of care. And then lastly, just wanted to emphasize how we see the primary care investment benchmark and the APM adoption goals are interrelated. So we are recommending a shared timeline for the APM adoption goals and the primary care investment benchmark. And here we expect that the emphasis on slowing spending growth will motivate investment in flexible primary care revenue streams via alternative payment models, and that the value generated from APMs will allow for continued investment and reallocation of the healthcare dollar to primary care to meet these 2034 goals. So this is kind of our rationale, which I'll share more about later, of having aligned timelines across the APM adoption goals and the primary care investment benchmark. So.
All right, Margaretta, thank you. A lot of information. I know a review for some. Richard, I'm going to start with you, and then I see Rick has 2 hands up, not just one, but 2 hands up. So we want to make sure to go to him, and then we'll give everyone a chance. But go ahead, Richard.
I almost want Rick to go first. Usually I'm very informed by what he has to say. So, you know, you spent a lot of time talking about PPOs, which, you know, I think one of the inherent challenges with PPOs is that by definition, a PPO is a product which people select if they're able to select. I mean, some people, they may not be given many choices, but if they have a choice and they select a PPO, it's because it has the flexibility to not have to be part of a network, a whatever. They can go outside of it, right? At the same time, on the flip side, for the person who's selling the product, It's a way to actually, depending on who you put in your network and you don't, you may selectively decide not to have certain people so that you don't attract certain types of people signing up for your plan, right? And they'd have to pay out of pocket. So although, again, people, actually, interesting enough, a lot of times people pick a PPO because they want the option to get some coverage for going outside of a network. And of course, when we have an alternative payment model, we were talking about doing capitation and actually keeping people within. That's why HMOs, you see 4 and out there, and you see with the PPOs, it's purple and there's no one at 4 and it's all just 3. So I guess the question is that when it comes to PPOs, whatever the percent, the percentage is actually less important to me in some ways is that, so who are those people who are in the APM in a PPO plan? Which patients are we talking about? And what sort of real arrangement does the PPO provide for those particular patients, right? Because clearly they have an option to go out. That's why they have a PPO, assuming they picked it, that wasn't their only choice, right? Because the PPO by sort of usually provides, this is the coverage you go out of a network, this is in network, versus an HMO, right? HMO is either you're in the network or you're on your own, minus emergency room, whatever else, right? I mean, that's inherently the difference between the two. So was there some discussion about, I get that, like, okay, we're going to take it out of everybody who's in the plan, right? And that's that's the whole numerator denominator question. But aside from just the broadly, okay, these are people signed up, are we actually looking at who it is who's in the APM portion of the PPO? I mean, to me, that'd be kind of important to know, like, what kind of APM are you providing? And so therefore, what are, who, because if the only people in the APM part are people who are generally healthy, who don't really have much need for it, goes back to what I was saying before, then I'm not sure we're accomplishing a whole lot. If it's really the people, the people who are signing up who have the more intensive healthcare needs, they're signing up because they want to be able to get some coverage so they can go out of network, and they're out of the APM and the APM portion, then we're missing the boat, right? We're missing the folks where there's the biggest bang for the buck. And also, frankly, it'd be interesting to know, if those people had a choice, assuming that why they decided to pick the PPO product versus an HMO product, right? And if they were restricted in where they could go, then that's inherently the definition of a PPO. You're not restricted, would they still have picked the plan, right? So does that make sense? In other words, I'm curious as to know who's in the APM, and then also for the folks who actually have the greatest needs who are in that plan, did they particularly pick that plan because they want to be able to escape any APM efforts that we're trying to put in some ways?
I'll just say I'm not sure that our data collection efforts, the way they're structured now, would be able to answer some of those questions about why members have chosen a PPO or who is in the APM. I think we do in our standards recommend prospective approaches. Many of the PPO attribution approaches to APMs are retrospective. So that is one issue where we've addressed that. So a provider knowing who their population is in advance and that they're in an APM and not retrospectively attributed to an APM is emphasized in our standards.
Would you be able to get data? I mean, we have all claims payer database that are in the data sets. Are we able to look at people who are going out of network versus in network? Yeah.
It's a good question. I don't know whether we can capture that in our all payer claims database. We can certainly take that back.
Okay, because I think that might be informative. I get it, you prospective versus retrospective. Any claims is retrospective, but I think you could look at, well, if you can tell whether they're in network or not, and certainly you know who filed the claim, so right. So you can at least tell what kind of services. I'd be particularly interested in more intensive specialty type services, right? And sort of thinking about, so you're taking that population, right? And what, which portion of the population are we taking? Is it the people who are doing a lot of these specialty services and so forth, are they in the APM portion or not? I don't know if there's a way to figure that out, even retrospectively, to sort of look at the pattern behavior. Obviously, you are trying to be forward looking, but sometimes looking back can tell you what's going on looking forward. So and maybe I should let Dr. Kronik ask his questions, because he has some better answers than I do. But I do think we're gonna have to dig in if we really want to make this work. We got to dig in a little more than just like what percentage of people in the total network, in the total PPO, were in the APM portion, right? Because I think the who, in terms of at least intensity of service, is going to be important, especially given the nature of what a PPO by definition is.
Thank you. Rick?
Thank you, Mark. Thank you, Margarita, for a really comprehensive presentation, and thanks for the revised standards, which mostly makes sense to me. I do have one question about the standards, one other question that picks up somewhat on Dr. Pan's questions, and then one just comment. So the question about the standards is about particularly the Medi-Cal standards. It looks like, in baseline, that APMs and Medi-Cal, you're thinking, are somewhat similar to APMs in commercial and in Medicare Advantage enrollment. Thanks for going back to that slide. I know it's 2026, so that's not, you don't have a baseline on here, but I'm assuming the 2026 is not too far away from baseline. And we're sort of below the commercial, but similar to Medicare Advantage. And what accounts for the much slower growth in APM adoption or standards in Medi-Cal over the next 8 years than commercial and MA?
Sure. So I can address that, and I'm sure others can as well. But in our discussion with DHCS, they have emphasized that it is challenging to implement APMs in the Medi-Cal market based on some of the baseline payments for Medi-Cal providers and how those are structured. One example is DHCS is currently working on an FQHC alternative payment model, which has been challenging to figure out how to restructure the payment so that it provides a prospective per member per month payment, while also still meeting all of the requirements for how FQHCs should be paid, or a need to be paid based on federal and state law. So there are some kind of nuances and challenges that are particular to the Medi-Cal market. And then we also just wanted to really work with DHCS to make sure that these seem achievable and feasible, and that these are grounded in how much they think they can move the market in terms of APM adoption. And I don't, if anyone else wants to add.
Well, the Secretary may want to comment on this as well, but CHCF has done a lot of work on primary care and APMs, and really trying to incentivize, encourage, learn from the FQHC experience. We have a lot of Medi-Cal patients that get primary care out of the federally qualified health centers, and frankly, the way that those clinics are reimbursed is not an alternative payment model at all. So part of it is the infrastructure that those clinics need to be able to do that. Part of it is the rates. And then part of it, frankly, is not losing the federal dollars that come to us as a state through an FQHC mechanism of reimbursement. So, Rick, it's a long, convoluted answer, as you can imagine, but I suspect that all of those things play a significant part. We also have folks that get fee-for-service from independent practices, many of whom are very culturally competent practices who have no infrastructure to be able to take on APMs. And so there are numerous impediments in Medi-Cal. I don't think this is a statement necessarily about the plans or their desire, but really a lot of the nature in which dollars have historically flown largely for primary care.
I appreciate that. Yeah.
Medi-Cal.
I appreciate that, and both those answers are useful. You know, a little bit surprising given that 2026 is no different, but maybe it's that Medi-Cal's done all of the easy work and the rest of the work is much harder. And it may just be as we move forward, if we do adopt these standards, be useful to have some language sort of explaining this. The second question, which actually is somewhat similar to the points that Richard Pan was bringing up, when we get information from payers on what fraction of members are in APMs, you know, levels 3, 4, et cetera, will that just be a single number for their whole membership, or will it be available by medical group or some other contracting arrangement? What will we know?
So we will be collecting data at the payer level, and we think that we can collect data by contract, so by percent of dollars in an APM arrangement, and then also percent of members in an APM arrangement.
I mean, I think I've mentioned once before that when I was at HHS and all this work was being done to develop this whole rubric, I was somewhat of a heretic about this. I think it would be useful moving forward, if possible, to be developing medical group level information, or maybe the contract level information crossed with medical group level information, to be able to, as we move forward, understand, you know, which groups are doing APMs and which groups not, or to what extent are they, and then to be able to connect that with the total health expenditure data that we'll be separately collecting, and or with the HPD data that will be collected. So to be thinking about the information that we'll be collecting, and will it be useful for expanding our knowledge about the effects of APMs moving forward. I'm here to speak as a researcher. And then the third is not so much a question, but a comment. I did see a comment from one advisory group member about the importance of getting this information, not just at the payer level, but at the medical group level. I mean, if you have a medical group that's being paid by capitation, but all the physicians are being paid on an RVU basis, you know, as we know exists in some medical groups in California, that is different from, you know, the medical group being paid by capitation and some of those incentives being passed on to physicians. And I know it will be very difficult, and it's not year one, but to sort of keep an eye on that moving forward, I would strongly encourage.
Yeah, thank you, Rick. Those are all really great points. Regarding the issue of kind of at what level APM adoption is occurring, we're first going to start at the payer level to get that data and get some transparency on how payers are performing. We also do have requirements in the statute about collecting from restricted, Knox-Keene Act, or limited licensees. So those are entities in this that are regulated by DMHC that take on global risk. So they're essentially providers that are taking global risk from a parent health plan. So that's going to be our first foray into collecting provider level data for both APMs and primary care spending. So we're going to learn from that effort. We haven't made a decision yet about kind of going down to the physician organization level, but kind of the sequencing is we'll start with payers, then the global risk entities, and then from there we'll kind of see what you know, what makes sense if for provider level reporting. We do have the authority to do provider level reporting. It's just the number of submitters gets quite large. You know, we're dealing with maybe a dozen or so submitters that are payers, and then a handful of RBOs or global risk entities. But the medical groups and IPAs, as you know, there's hundreds of them.
That makes sense. Thank you.
Okay, thanks, Rick. I'm going to go Elizabeth, and Ian, and Sandra, Don, and then David. So go ahead, and then back to you, Richard. Sure.
Thank you. I was actually on HCP land when we came out with that framework 8 years ago now, and the glacial pace of healthcare transformation continues. So we need another 10 years. So I would be in the camp of thinking that this is a bit underwhelming in terms of pace, but that's not the focus of my comments because I've already made those. One of the things that, and I think this actually aligns with what Dr. Kronik was saying, is if we are not measuring quality and cost at the provider level, there's really no point in doing this, in my opinion. We could be changing to APMs all over the place, and if it's not improving quality and cost, we shouldn't be doing it. I mean, it could potentially worsen quality and cost. So we have to track outcomes and total cost of care related to the APMs, and I think that has to be maybe at the provider level, but we can't separate the two, or we won't know that we're achieving anything. Secondly, I don't understand why we are having a higher bar for Medi-Cal than commercial PPO. Like, why can't we expect them to at least meet the standards that Medi-Cal is meeting? Because they clearly, I mean, I would assume they have the resources to do that, and they magically were able to do it in Medicare Advantage. So, do we have any sense of why we're not holding them to the same standard?
For the commercial PPOs, I think it really comes down to the challenges we've heard related to attribution and attributing members to an APM and having that prospective payment in APMs. So I think that's the challenge that we've heard, that it's quite challenging to develop those attribution models for PPOs and make sure that members are they're either a population that's designated and members or providers are paid prospectively related to that population, or that the attribution is clear in terms of shared savings and shared risk arrangements. So I think that is that's one of the main challenges that we've heard. And then also just based on where the baseline data is now with 16%, we felt that 60% by 2034 seemed achievable, but aspirational also.
Okay. I will just be on record that I think we should have consistent expectations, particularly for the practices who will have to live with these different payments. Another question I have is, as purchasers get impatient with the pace of change and look to direct contracts or other arrangements that can actually do this faster, how will they be reflected in the data? How will we know about them?
I'm not sure if our data collection efforts will be able to track direct contracting since we are collecting data from payers. Vishal or?
This is direct contracting by an employer?
Employer purchaser with a provider group who is ready to enter into a different type of payment arrangement.
Yeah, our data process or data submission process is on payers. Like a purchaser wouldn't be a reporter under OCA. So yeah, I'd have to think about that more, but yeah, I don't think we would capture direct contracting.
It might be worth considering how to get some insights from those lessons, because they are happening. I will tell you, my members who do direct contracting are seeing, 30% reductions in total spend and better outcomes. So at least lessons learned might be informative and that's not just in California, it's elsewhere. And then finally, and I promise I'll stop, I was sensitive to Don's point about, giving credit in the measurement of meeting the threshold, or the target rather, but we're seeing an explosion in this whole new industry of value enablers that have the real potential of just adding more costs. It's just a whole nother administrative layer. And I would want to be really careful about just sort of giving them a pass for spending on these new entities that may or may not add the value that we're looking for.
To follow up on the direct purchasing, is that are there still kind of claims flowing for the?
In
okay.
some cases.
Okay, okay, but it could be also non-claim spending. Okay,
exactly.
Okay.
Yeah. Thank you.
Ian, before you go, I just think the point you made, and Don, your point, obviously it could add to costs and make some reason for missing a cost target, but I think your point is there are certain strategies that could really be part of even a performance improvement plan and moving the needle against costs too. So
I know I'm going to do this out of turn, but I just want to add on. I do think if we're going to, if the lever here is really in the assessment, we need to be really specific about what the rules of the game are. One, in fairness to the entities that are getting reviewed, but also to send very clear signals about what counts and what doesn't, and how it's going to be measured and so forth. Otherwise, it's not helpful, and I think potentially the opposite of helpful.
Yeah, I echo almost everything Elizabeth said. This isn't to disagree with Richard's point on PPOs, but you know, people opt into PPOs. I don't question for the choice or the illusion of choice, but that's not contradictory to people wanting a PCP or being open to having a dedicated PCP. An advisory committee member maybe facetiously suggested one of the metrics should be, can the enrollees identify by name their PCP, which resonated to me. I would fail it. But a lot of, at least multi-employer plans, select PPOs because their enrollment spreads a geography where HMOs don't fit nicely, or because they believe, often accurately, they can do better given the market dynamics in which their membership is concentrated, and it is in those settings you're seeing direct contracts popping up. Although I'm not sure how scalable that is in California. The question, Margareta, for you I had, we received public comments suggesting that in addition to the demographic metrics, we collect income. Maybe I'm adding to this, but you know, a spread of the enrollment by income bracket, household income bracket, given the role income plays in social determinants, getting to Richard's point of understanding who is in these APMs. Is that something that you've considered? Have you rejected that? I don't see it called out here, although it's not contradictory necessarily to number 6 in your recommendations.
Sure. Yes, we've discussed this in the work group before, and our perspective was that standard 6 in terms of collecting demographic data was broad enough to include other types of demographic data, not just race, ethnicity, disability, and SOGI data. So that's why we don't have it specifically called out, but we felt that you know, collecting demographic data could include more than just real SOGI data.
Thanks, Ian. Go ahead, Sandra.
First, let me just say a tremendous amount of work and thinking and input. Really appreciate where we are thus far. I guess I want to put a pin in the notion that while you know, collecting data from 11 payers is probably more manageable, I actually think the place where this is going to matter most is at the provider level, and seeing how it's actually transforming the delivery of care at that space. Keep in mind, I don't know how many years back, we decided we were going to capitate most things in this state, including Medi-Cal, with the idea that focus would be on population and outcomes. If you look at many of the outcomes that we care about, capitation as an alternate payment mechanism really has not improved outcomes in virtually any category that you'd look at. So if we learn from that, it would suggest that till you get to really understanding what the providers are doing, how they're incentivized, what kind of practice transformations actually happening, my sense is this is a pretty blunt approach because I don't think measuring at the plans is going to tell us all that much. So whatever infrastructure we need to have to get there and to get there quickly seems to me will get us much closer to what our ultimate goal is. And then as it relates to quality, I totally appreciate that these should be linked to quality, but it would be also helpful for us to name what those measures are that are most important in quality. Covered California has taken a shot at this from my days on that board and really named 4 key measures. I don't know whether those are the right ones, but I would encourage us to align there too on quality measures and be really clear about what quality it is that we're looking for, not just tie it to whatever a plan determines might be the right outcomes. So a tremendous amount of work. On the PPO issue, I think Dr. Pam raised a number of important issues, and I know you grappled with the attribution issue. And it's true that people who sign up for PPO typically want the ability to go to other networks, largely for specialty care. And so thinking about folks who are in PPO and where they get their primary care, even if they're going out of network for all kinds of other things, might be a way into this attribution piece that would be helpful in moving the PPO product line better aligned with where we're trying to go with this. But a tremendous amount of work. I really appreciate all the input. And again, the sooner we get to providers and really understand what's happening there, the faster we'll get delivery system transformation, I think.
Thank you, Don.
Thanks. So I also echo the thanks for the terrific work. This is all very helpful. I guess, just kind of going back to an earlier point or question that I made, which was followed up by a point. I do worry that, and I appreciate that this is, as I understand it, the legislation's fault, but we are setting goals that we really don't have levers to do anything with, meaningful levers. I mean, the idea that they come into the assessment is a marginal lever, I would expect at best. Among other things, you would only have that lever for folks who have missed the goal. So, I think it's worth thinking about how we do something about this, because that's frankly more important than a goal. That's point one. Point two is that in the PPO environment, I worry that, so assuming that the goal of an APM is getting patients to high quality, lower cost care, a lot of the tools that PPOs use, or people who put together PPOs use, really are outside of the APM framework altogether. And I just, here are some examples. So the increasing use of population health managers. So these are folks who work with large employers to engage their members or enrollees to identify the right care at the right time and the lower cost, higher quality providers, really outside of this framework with the same goal, the thing that large purchasers are increasingly going to. Another example, the use of curated networks, right? Picking the doctors and other providers right so that you have a higher percentage of high quality, lower cost providers in your network. A third example, benefit design. So paying, for example, for non-medical interventions, for food supports or targeted home care when it's going to dramatically increase outcomes and lower readmissions, et cetera. So those are all things that are in a lot of ways better suited to the PPO environment than APMs, which I think of as sort of a traditional HMO intervention, that when we just sort of adopt the verbiage, APM, we're almost excluding by definition that if the goal is higher quality, lower cost care, we shouldn't be excluding. So just putting that on the table is something to think about here.
Appreciate that, Don. David?
Yes, thank you. And I just want to recognize the effort that went into the revision here as well. Very complex, very hard work. I agree with the comments about PPOs. I think this is all accurate and is a major challenge, major issue. I want to focus more on the Medi-Cal population, however, and say that recognizing that moving from 55% to 75% is maybe a small delta, but it's kind of a Goldilocks thing too. I know it's a balancing act and it involves some externalities that we don't have full control over. But I did want to emphasize the importance of the Medi-Cal population, recognizing that it covers about 1 in 3 Californians these days. Many of those members are formerly uninsured individuals. And I would say the importance of this population is reflected in the fact that a lot of our healthcare disparities and maybe adverse outcomes may be seen in this population. And to the extent that we can actually begin to assess both the cost and quality of care, any improvement in this area, I think, would be definite return on investment for the state of California, given the vulnerability of these populations. So I just wanted to applaud even the 75% target, even 10 years out.
Thanks, David. Richard, I want to come back to you.
No, thank you. First of all, again, I mean, I think we need, I'm certainly in support of trying to move more toward payment models that are going to link to quality improvement. I agree with the comments that people said that it really is about at the provider level, right? So we're way up here and what's going on down here. And sorry, I've been in situations where my incentive as the person on the ground is very different than the system. You're not seeing the behavior changes that you need to see. Because ultimately, right, these APMs, the promise of the APM is actually the behavior change. I think the 30% is because they actually got down and far enough into the system that the people on the ground, the people actually seeing the patients, actually, were willing to change their behavior and also invest in the changes in the systems necessary, right? Because you look at your clinic and you go, well, okay, I have a limited amount of resources. What do I invest in, right? How much time and effort, in addition to seeing patients, we got to do to change the processes we do in our clinic in order to improve the quality of care? I mean, we want to do everything we can, but we got only a certain amount of bandwidth, whether it's money, time, or anything else, right? And so you need to be sure that's flowing all the way down so that makes sense, right? I don't know how many times I said, can you just please capitate the primary care piece? Because if I'm always competing with a specialist for stuff, it's a no-win situation for me, right? I can never generate the kind of RVUs the specialists do, right? And so can you just capitate my piece, tell me what the capitation is, and let me do the best I can with that work, right? And so if that isn't happening at the baseline, that's not happening. We're not going to get behavior change. I do think one of the things, I appreciate one of the comments Dr. Hernandez made about Medi-Cal. We talked about some of the struggles. You made mention about individual practices, small practices that provide culturally effective care that don't have the infrastructure. I'm not sure that those are only in the Medi-Cal system. Those do exist for, yes, patients with perhaps probably not wealthy, just slightly, but they're now in the they're not in the Medi-Cal population. But, so we do need to provide and talk about rural communities as well, where there's lower density. So as we set these percentages, I think we need to be very sensitive to how we can help those practices actually make the transition, because they don't have a lot of extra resources. And if the plans are, and the problem is this is the tension, right? If we're operating at the upper level, the easy way for the plan to hit the percentage, I realize that there's not a whole lot of leverage we have to make them hit the percentage, but if they are seeking to hit the percentage, an easy way is to simply cut out all those folks, right? That'll bump up your percentage, right? And that's not what we want to happen. All right, so they could either put more money and invest in trying to do the transition, or they can cut them all out, right? And what we don't want to do is stick a number, a target, without seeing what's going on underneath the hood, right? Because actually we may have, frankly, behavior that's not particularly positive for patients, right? We creating access problems and so forth. So I think we need to think very carefully about that. In fact, I think in the original proposal, the deal, there was supposed to be, I think, several $100 million to help practice the transition. I know we're in a challenging budget situation. I think that I don't know what's happening with that money, but somewhere we need to provide those supports. So again, even for the non-Medi-Cal patients who are still working class, et cetera, so that they can still see those individual practices that are culturally specific for them. So hopefully we want to recognize that whatever goal we set, we're not going to actually drive them out of the system, make their, have payers say, I'm excluding them because in order to hit my APM percentage, it's too expensive for me to, so let's just cut them out, right? So we don't want to have that happen. And then I think on the PPO side, I do think there's a place to look at, aside from just a broad-based, percentage, perhaps, and again, I'm not, maybe someone else has a more clever or better solution. We might want to think on maybe even at the, what the percentage is at the primary care level, right? I think was Dr. Hernandez suggested, right? Because it's possible that, maybe on, because they can by definition of PPO, right? And again, it could be they're in a plan because their employer just, doesn't, they're spread, the employees are spread out so much, it's hard to pick an HMO, so they go PPO. But there are also people who pick it. But at least on the core primary care, coordination care side, which hopefully they should be contracting a network sufficient for their patients, that should be a little simpler, that what percentage of that part of their thing is an APM versus just trying to say everything. So maybe having 2 layers there, perhaps, where we can recognize that's going to be a little harder to control the larger piece, but maybe the core, after all, it's a preferred provider. The preferred provider part of it, perhaps we can measure the APM level on that subsegment as well as the total. That may actually still move us in the place we want to go in terms of needle, which is really about quality and cost, right? It's better quarter than simply saying, well, we're going to have a big number, and so but there's parts that's a little more out of the control over the PPO by definition because it's a PPO. So just a thought there, perhaps to try to when we say what percentage, to look at that, maybe subsegment may actually get us as much bang for the buck than a percentage of the whole thing in a PPO type arrangement.
Okay, first, very rich discussion by the board as usual. Thank you. A lot of different perspectives. I want to just return to the team and ask a couple of questions because today we have this on the agenda as an action item. And the action would have been to vote both on standards and goals around the APMs. A lot of the feedback that I'm hearing is, and I don't want to, I'm looking for confirmation or a different approach that maybe we're not quite ready to jump into percentages as the goals and maybe looking for some other approaches, but I want to hear if that's where the board is before we go to public comment. Do we want to keep looking at this a little bit longer, or were people prepared? Go ahead, Richard. Or I saw this one. Go ahead, Richard, and then Elizabeth. I'm sure it won't matter.
I think it would be helpful to have some refinement. I appreciate all the work, and there's a lot of really hard work and really great presentation. Now, it's possible we could also say this is the broader, or we can refine. I mean, there's some of the refinements I think could fit under this framework, but I do think there's more refinement that's necessary. And I know I made this remark before, but I also think again, I actually want to also think about how do we focus, bandwidth wise, we'll get everybody, but that, let's say the 20%, the sick is 20%. I want to be sure that those folks are actually benefiting. If I'm going to target where I'm going to try to move the percentages up, it's going to be the people who have the most healthcare needs, right? If everybody's great, but if I really want to care about moving the needle, I hope that we have a way to also focus on that population across all the different plans. Versus it's great to have the number for everybody, but I'd like to know what it is for whether it's 10 or 15 or 20 of the highest spend patients, what level of APM they're in.
Thanks, Richard. Go ahead, Elizabeth.
So it might be all the quality subcommittee time we've spent together, but I am in largely agreement with Dr. Pan. I'm not opposed to having percentages, but I don't think that is actually measuring what matters. What matters is care getting better and is cost going down. And I think we have to have a way to look at that in relation to increased adoption of payment models, because otherwise we don't know if we're achieving anything. And to Sandra's point about having aligned metrics, what do we mean by success? I think we could do a lot there. There's been a ton of work done in California already on that. And so maybe to give a sense of direction, what we're hoping to see with the changing payment, I think would be an important addition.
Others? David?
I would agree also. I think, given the significance of these decisions, both for the standards and the goals, there's probably little lost with some additional efforts at refinement to make sure that we are getting everything as on target as we can get. There's significant downstream consequences to this decision, and this may be a time, and unless there's a goal or a need that I don't see necessarily, for us to be a little bit more deliberate in how we're going about it, which I would support.
Sandra?
Yeah, I guess more time to talk about some of the things that we raised today would be helpful. It may not has much to do with the targets per se, although the PPO target, you could argue, is too low, and we probably would, given all the things we've talked about with regard to that particular structure. The concern I have is that the board's opportunity to get into the how and the what is really constrained by these activities. And so if we approve these today, we go off and sort of try to implement it. And I think some of the details that we talked about implementation and where we're going to measure are super important to what we're trying to achieve. So in that spirit, more time might be better in order to address those.
Other comments on this? So one of the things that I think, if this is the direction we're moving in, we have to be, as a group, pretty clear with the team what it is that we would like to see come back. And we heard a lot. And I know we have other things on the agenda, but I want to make sure that we take a few minutes. I can't wait to hear public comment as well, but tend to feel that we shouldn't put this action item in front of the vote today, but would like to spend a few minutes to hear from folks what additional information, what exactly around maybe PPOs, the segment of the population that we know spends the most, a little bit down to your questions about, well, how will this actually build into a consequence or an impact in a performance improvement plan, or somebody who missed the cost target, some of these factors, the Medicaid, the PPO conversations that we've had. Love to hear specifics. Rick, you as well, please. I think it will help Elizabeth, Vishal, Margaretta really come back next month with something that we can dig into a little bit more. We won't necessarily miss a statutory deadline if we do this next month, but I fear if we don't get this piece clear, then we're going to be in a 2-meeting process, not a 1-meeting process, and then we miss the statutory deadline, which I know we'd prefer not to do. So before we go to public comment, I'm going to ask the board to let us know, try to be really specific with what might help us feel a little more prepared next time. Great. Rick, I'll come to you. Richard. Oh, go ahead, Rick, and then we'll come to Richard.
Thanks. I think that maybe what would be most helpful is as clear a connection, as clear a plan as is possible to connect the adoption of these targets to anything that we really care about, the improvements in quality, the reductions in cost. And, you know, we've heard, I think, from really every board member saying, you know, I know the statute requires us to adopt targets, and so that's what we're going to vote on. But I think we would all, as I listen to fellow board members, be more comfortable voting on those targets if we had the sort of connection document or the logic model that suggested what information we might be OCA might be collecting in the future, or what OCA might be doing in the future that would get from the targets to the outcomes that we care about.
Thanks, Rick. I think that resonates. A lot of nodding heads here, really the punctuating point. I do just want to, before others speak up, Vishal or Elizabeth, Margareta, one of you, could you be clear on what we are required or asked to adopt? Because we have maybe interpreted the statute to mean percentages, and maybe that's not exactly what is required, but could you be as clear as you can be about that?
Yes, the standards themselves are the practices to inform payer-provider contracting, and then the adoption goal is a numerical goal for measuring the rate at which alternative payment models as a percentage of total healthcare expenditures. I think we might have some more specific language in the statute that we could show.
I was trying to go to it, but yeah, statute does require us to adopt a goal either by percent of dollars or percent of spend or percent of members attributed to APMs, and then standards for payer provider contracting.
Okay.
So it's both the standard and the adoption goal. And so we have the 1 through 10. And then in addition, the goals reference the land 3 and 4. So if the board had, right, Margaret, if the board had direction as to changing the definitions of land 3 and 4, or the 10 items that we include in the standards. So it's the standards and then the numericals.
Thank you. Go ahead, Elizabeth.
Just a clarifying question. So we will have visibility into those contracts to make sure that that's happening?
Not the specific contracts. We would get data from the payers on the adoption goal, which is the numerical goal. And there would be data collection associated with that in terms of different buckets. We have the expanded framework, which is more detail to the HCP land categories. But the standards themselves are more about promoting APMs and a set of best practices for payer-provider contracting.
And I would just add that I think more transparency is likely required to make sure that these payment changes are actually reaching the providers, which is the goal.
Yeah, I think that's one of the fundamental overarching questions is, can we get there through this mechanism? And then what is the transparency associated with confirming our ability to do that? And I'm hearing, I'm curious how much you can, between now and the next meeting, clarify that point, but I think it's worth an effort for sure. Okay, Don and then Richard.
So I think a few thoughts about maybe additional measures. One, we are picking a percentage for everybody, but we might want to think about, again, and sort of looking at staff in terms of, do we have the data to collect it, or can we get people to report this? Is that, for example, on the PPO side, right? I know we're going to be talking about primary care later, but for example, is there a way to look at what percentage of, I guess, a set of providers or services or something like in their network is in a PPO? So I get the, like, let's just capture everything, but actually I think that that sub-segment, the percentage there in APM may actually be informative for a PPO type arrangement, right? And that's where there might be actually greater ability for the plan to move. It'd be helpful to have that greater transparency Elizabeth talked about, and you'll explore whether you can do that, but at least know what that is, right? In terms of the APM arrangement, may provide some insights. The other thing is that again, I do think that whether there's a way to say, hey, out of your, I guess top 20% highest utilizers or whatever else are, amongst the beneficiaries, what percentage of them are in it, APM arrangement versus your whole population, right, et cetera. So maybe that, I think, again, trying to get some sense of that, or the other approach would be is, for example, we talked about linked to quality, right? And we may actually, like covered California, say there's a set of quality measures that maybe it's the same ones because we want to do alignment. And so therefore patients with those particular diagnoses that are attached to those, we want to know what percentage of them are APM arrangement. That might be another approach, right? So so you can both look at the quality measure, but also look at, hey, are those APM arrangements leading to, and so that linkage, and also having information about what degree they're in the APM arrangements, I think may perhaps again provide insights and also direction as to. I appreciate that we're going to look every 2 years, exactly how much that might be moving the needle, and then I think that. And I do think some way of trying to figure out whether it's directly through the plan, or maybe even since technically you should know who contract, whether we go through surveying the provider or something to get a sense of what are the providers on the front line and what do they see their own incentives being, right? As well, sort of like closing the loop, right? So we're getting information this way, but maybe we should get some information the other way and see, and especially if we have some information on the quality side, if we have the quality measures, maybe that can also be informative as well. So, and it turns out it's not very informative, we can stop doing it, right? But some way to try to get down to the front line, what the incentives are on the front line providers are actually feeling like they're experiencing in that regard. So I think, I don't know if that's specific enough in terms of setting standards or things to do, but some thoughts about that.
Yeah, Don, before you go, I think just to echo a few things and maybe even ask, you had the slide about what Oregon's experience is. I'm wondering, especially in light of the sort of population application around APMs, is there any experience that other states have looked at your question? I'm not sure that in a few weeks or a month you're going to be able to really look at that subset. I wonder if there's some learning from other states that could be helpful to the board in thinking about APMs broadly applied versus to specific groups that might be useful. And then certainly, again, reaching out, covered California, as a member of that board, I'm proud of the work that happened there, and really a lot of connection between what a contract looks like, how people are paid, and some of the quality-based measures and incentives, frankly, that goes into that contracting, what alignment there might be there. And then on the Medicaid contract, just to the point of getting to the providers, we really struggled with what that contract could look like to get just beyond the plans into provider land. And it's not easy for sure, but I think there's hopefully going to be some experience over this year and next year that could inform the board moving forward on what that looks like. I'm not sure that we're going to get all of these answers in a month, but I think being open to those revisions that we can make and know that maybe we vote on something next month that is imperfect because we have some gaps, and come back to that is what I want the board to get comfortable with, because I'm guessing that's where we're going to be given the rich interest around the table on what we want to see come our way next month. But that said, Don, go ahead.
I think I'm in agreement with Dr. Pan that, assuming that we don't have levers to make these things happen, that the best thing we should be searching for here is information, and to that end, I would think about expanding very broadly what counts as APM, to think about some of these things, for example, that are easier to fit into a PPO model. I mean, I would up the percentages for PPOs, for example, and include all of these things that are not the way that we've traditionally thought about them. And then I would just ask people to sort of, I mean, self-identify, right? Yes, we have APMs for, you know, in X% of our population, and this is what we do, because then when we're looking at data and looking at spending in particular, we are potentially in a position to identify things that are working, which I think is probably the best thing that we're going to get out of this. So just.
I personally appreciate that point. I think the categories 3 and 4 are generally helpful, but probably not specific enough to actually what people are doing as an alternative to traditional payment. I think, Elizabeth, part of your comment about how maybe old that framework is there's been some serious evolution in knowing the granular details on what those quote APMs are would be helpful. So just considering how we capture that in the framework would be useful. Okay, Ian, go ahead.
A specific question, Eric suggesting look at an experiment like example by the level of current and the national PTO will edify the FPHC were very
That's helpful. Other specific comments? Okay, I'm going to turn to Elizabeth, Vishal, Margareta. Do you have anything that you want to hear from the board in terms of the follow-up besides I wish you all stayed at home today?
No, this was all great feedback. Regarding the issue of the quality measures, we in our standard and our implementation guidance, we do suggest that payers and providers align with existing measure sets, including from DMHC, which will soon be reporting on their quality and equity measure set, and then other data sets that have been prioritized, such as the 4 measures that CalPERS covered, California and I believe DHCS are aligning on. So it is in there in the implementation guidance, but if there's anything more specific you're looking for, happy to listen to that. And then the other issue with the clinical risk scores for this kind of the sickest members and making sure that they're, or the highest utilizers, making sure that they're being served in an APM. So kind of, we could take that back and see kind of how that could be structured data. I think we're not trying to make it be like qualitative information, like kind of narratives. I mean, narrative information could be really helpful to provide context, but we do want it to be something quantifiable. So just kind of wanted, we'll do our own due diligence on this, but is it something like a risk score that maybe of the members in the APM, or is it something else?
Well, I think in the most simplified form would be just actually even just knowing what percentage of those patients are in an APM type arrangement for their care, right? Because my guess is that that percentage may even be lower than the average for the whole plan. So yeah. But that's really where the opportunity is if we're talking about cost savings and even quality, right? So I think even just knowing that information itself may be informative to have that measure. I think ideally, we could dig in a little more deeply into that, but I think even just knowing what percentage of people who are the highest utilizers are in an APM arrangement, and then I think when we start working on the primary care part too, I mean, I think, again, this is where the biggest bang for the buck is, right? This is where we spend most of our money. And so someone has a percentage and they tell me they're 65%, but 65% of the healthiest people, I'm like, okay, well, that's great. I appreciate that, but that's not where we're trying to, that's not where we're going to bend the curve, at least in the short term. Maybe in the long term, that's going to help a lot. So I do think that just knowing that percentage for now would be very helpful. I'll have to think a little more about, are there additional pieces of information that we don't want to just collect information for its sake, just I don't want to create more administrative burdens, but I just do want to think about how that can inform what they're doing. So, I mean, another piece would be is like, okay, we say, and if they have an APM, exactly how broad that APM works across their entire care. Is it just the primary care part? Is it actually all the care, et cetera? I think that would be interesting to know as well. What is the nature of the APM, right? For that, you would think in an HMO type arrangement, it should be everything, but and it's so, but it depends, right? Do you have a group that the subcontract, what the group may be, but I realize that gets into a lot of details, and that's bad. Maybe that's bad. But just even knowing that percentage, because if we find out that the percentage of people who are the highest utilizers are much lower APM than the rest of it, that's frankly, I don't. If the rest of it stayed the same and we just increased the percentage there, and then even if the whole total increase just increased a little bit, and we really work to move that percentage up for that subpopulation patients, I think we're going to see a lot more bang for the buck in terms of effort than just trying to move the whole needle for the whole population. So that's just my thought. And then I guess one other comment is that I would like to think about, maybe it doesn't have to be pinned by next month, but some measure of continuity. I know I mentioned it before, but we haven't really talked about, because I think that, again, that's, and frankly, even beyond a year, right? So if there's any way to do that, at least, because I think, again, we'll touch on that also, I think, when we talk about primary care, but this issue of continuity is going to be really important because, again, I think better utilization, actually better, all those wonderful things that we hear about. So finding some way to assess that, whether it's through this or as we talk about primary care, to have some way to collect data to find out how long someone's able to stay with the same, essentially, team, or are they constantly churning teams, especially on the primary care end.
Okay, Elizabeth.
Very briefly, and this may go without saying, but I think we've got to make sure this is stratified, like real and SOGI data included in understanding impact. And then secondly, I think I would ask that we specifically revisit the PPO target percentage level.
Yeah, I think the number of people share that view, and I think Don said revisit it and maybe consider expanding what counts as an APM. So it goes hand in hand. Okay, again, turning to the team. Elizabeth, anything else?
Thanks very much. No, I'm not wishing I stayed home this morning. I appreciate.
No, that we stayed home.
Oh,
you were
okay.
happy to come to work. Yeah, but that we all had flight problems and got here late.
We very much appreciate the incredible expertise of this board and the commitment and how much you all are digging in and advising us. So we have a saying at the HPD Advisory Committee meeting, crawl, walk, run. And so I just want to temper expectations a little bit that Margaretta has a small and mighty team that we've been working, for almost a year on this. We are not going to be able to capture provider data right off the bat. So the board is statutorily obligated to adopt the standards and the goals by July 1st. So you'll do it at the June meeting, and this is all incredibly helpful feedback that we'll take back, and other specifics, continue to be welcome. And I think we'll need to continue to iterate, right? So just like we've committed to revisiting the target, we can revisit this. So I think we'll take back suggestions, keep giving them to us. We'll do as much as we can in the next month, and also have time to iterate as we move forward.
Great. Okay. Let's move to public comment.
At this time, we'll take public comment on this agenda item, draft alternative payment model standards and adoption. If the comment is not on that agenda item, please reserve it for the appropriate agenda item or general public comment. Looking virtually, seeing one hand raised, and if you have a public comment in the room, please step to the podium. Yes. Okay. Catherine, virtually, please go ahead.
Okay. One, thank you so much to this committee for all the work you've done. This is Dr. Sullivan. I have been in the health service delivery side of what you're talking about. And there's something I want to point out that I think is really important for us to remember is from between 2016 and 2026, we've had a pandemic. Okay. Which put a huge burden on the primary care providers and all of the physicians and the population. And so that also gives us an opportunity to do something transformative with this group. And what I've been suggesting is that we kind of go back to something that we talked about earlier before the pandemic, which was the health home. So the PCP is the primary care provider, but he needs or she needs help. So she can't do it alone. And so what people have been saying, which I really agree with Dan and Dr. Pan and Richard and Elizabeth, you're all new people to me. But what I'm hearing is actually the same thing. We want to help improve quality at decreased cost. One of the things we might consider is doing a demonstration project. You have two incredibly large groups to work with. One is Kaiser and the other is Covered California. Now, I've reached out to both of them to ask about how can I help? I just want to figure out how can I help. And in talking with someone I know at Kaiser, they're saying, well, you know what? Yeah, I guess there's a way to help, but you might have to talk to the health plan. And that's what you guys are saying. We should talk to the health plans. But on the other hand, we should be talking to the providers. And who are the providers and who are the beneficiaries? The beneficiaries are the population of people who can't sign up for a PPO. They literally can't do it. And so they're the homeless, they're the Medi-Cal recipients who are uninsured, they are the mother with 5 children. And therefore, I do agree with Dan, we have to define the population and then say, this population needs a PCP and a health home. Now, who's in the health home? These are the expert providers who could actually support the PCP in case management and care coordination. So I highly recommend that we think about a demonstration project, a post-pandemic demonstration project that addresses the needs of the population and of the PCP. And that's my comment to all of you. And it's a huge problem that we have, but a great opportunity. And, prior to the pandemic, none of the physicians knew how to Zoom, and now they do. So there's a great opportunity there to use technology at the primary care level. So thank you so much for talking. And, Dr. Carlisle, hi. Dr. Geely, hi. It's me. I'm still here. All right. Thank you.
Thank you. To the individual at the podium.
Janice Rocco on behalf of the California Medical Association and member of the Investment and Payment Work Group. CMA is generally supportive of the proposed APM standards. In terms of standard number 10 about assistance, we wholeheartedly agree that's necessary. Before the passage of the OCA statute, there was inclusion in the state budget for funding for small and medium-sized and particularly rural practices to help with the shift to APMs. Unfortunately, the May revised proposes to sweep that funding. So we hope that at some point there is funding for this work. In terms of the adoption goals, some of them seem unrealistic, particularly for PPOs. We were told PPOs are currently at 16% during the work group meetings, and for Medi-Cal enrollees, the latter population obviously being one with disproportionate healthcare needs and CHRM in terms of their enrollment. We suggest looking at where we are today in each of these segments and then building incrementally as opposed to, if you want to grow by X percent per year, as opposed to just having, the goal at the end. I realize that we do it over 10 years, but still, if you set a percentage and then try to grow by that percentage over time, it might make more sense. And in terms of the statute makes this shift to APMs voluntary. It uses words like encourage, facilitate, promote as what OCA is supposed to do, but not require it. And as we heard today, OCA is working with Covered California and DHCS to have them put this in their contracts with the plans to then force it on the providers. And that's not voluntary. So we don't have funding to help folks who were not early adopters. And now we seem to be talking about putting it in performance improvement plans, which again seems to be a way to force it on folks. So we would just like to have a discussion about how to encourage, how to make it possible. What are the things that we would do to make it more possible as opposed to trying to force it on folks?
Thank you. Looking virtually, Mohit, you are unmuted.
Thank you very much to the board for this discussion today, and thank you to the advisory committee as well as the investment and payment work group on which I serve on behalf of Anthem and Elevance Health here for all the work that's gone into this. I think I want to echo Dr. Pan's comments on some of the PPO structural issues that have been reflected here, and also comments made by Don Moles that there might be different ways of measuring the level of interaction that we can get both from our populations that we serve, but then also from the provider community. I still want to emphasize that even when you look at very specifically the uptake, and I think Janet was making this point just briefly here as well, that we really have to meet the provider community where it wants to be met as a health plan. It's very difficult to force things even within contracts because the only other option is to not have people in our networks. And then you end up in a situation where you don't have network adequacy, and that reduces access and by default would reduce quality and equity as well if people can't even see a physician that they need to see to begin with. So there's got to be a balance here. We've maintained that position throughout these discussions where, we understand that we want to get to this concept of APM and then in the later discussion around PCP payment as well. But I really think we have to meet the provider community and their ability to absorb such levels of change. In fact, I'd be interested to know from a comment made earlier, how many FQHCs and what percentage of the population in Medi-Cal out of 14.5 million people are actually covered by the FQHCs who signed up for the APM program. And how does that comport with the PPS system as was raised? If you're returning money to the federal government because of an alternative payment arrangement, that doesn't necessarily help Californians. So there's many different issues that we've worked through in the investment and payment group, including such issues around PPOs. So I'm very hopeful that that the board has decided to continue the discussion, maybe analyze a little bit more before making the votes. The last thing I'd point out is that when you look at the PPO versus Medicare Advantage issue that was brought up earlier, let's not forget that Medicare Advantage, going back to the ACA and even before, has had ACO mechanisms built into it where providers have specifically been incentivized for a decade to come up to speed on alternative payment methodologies and ways of interacting with Medicare Advantage plans. So the extent to which the PPO system is not there by default, because it is a much more open-ended system, we do need to take that into consideration in how we set these rates to measure over time. So again, thank you to everyone for all the work here. I can tell you we are very engaged in our work on the investment work group, and we appreciate that the board is taking a measured approach.
Thank you. To the individual at the podium.
Beth Capel for Health Access California. This discussion is exactly why the law didn't set requirements. The law is broad in its description precisely because we knew there was a lot more work to do to figure out what was the right thing to do. The law says the office shall promote the shift from payments based on fee-for-service to alternative payment models that provide financial incentive for equitable, high-quality, and cost-efficient care. It never specifies what those alternative payment models are. What you have before you is a proposal based on the HCP LAN structure because that's the most commonly used, but the insights that this board is providing suggest that there's further improvement that could be done to that. In addition, I'd note that it says the office shall set benchmarks that include but are not limited to increasing the percentage of total healthcare expenditures or the percentage of membership covered by an alternative payment model. So that gives you, and perhaps not by next month, respecting that staff has now worked on it for a year, but gives you over time the opportunity to look at additional benchmarks, whether it's higher utilizers or other things. The final point I'd make, none of which is in our letter because we learned this more recently, is that we understand that a number of other countries that have universal coverage systems have moved to capitation payments for their primary care providers, in particular. The province of Ontario, apparently Denmark, perhaps others, Don Moulds probably knows better than I. And these are, it is because of the rat wheel of fee-for-service, as Dr. Duncan Parker said at the advisory committee meeting, it makes much more sense to have a primary care practice based on a capitation model. This was also something that the pandemic drove home for us, was the disruption was much worse in the fee-for-service based side of the industry than the capitation based side. So we would encourage further work. We would also remind us we're at the beginning here, not the end. So there's opportunity. Thank you.
Thank you. Looking virtually, Lisa, go ahead.
Good afternoon, Lisa Fulberg, CEO of the California Academy of Family Physicians. And on behalf of our over 10,000 family physicians and residents in California, we really want to thank the OCA staff. Just seeing how hard they have worked has been an incredible part of the process. And thanks to members of the board for your commitment to prioritize primary care and advance these efforts to make quality preventative care more accessible and more affordable. We are supportive of the 10 proposed APM standards. We think that these standards make significant strides in moving towards a value-based system that really does provide incentives for primary and preventative care, which of course our current system is short on. We're really pleased that the standards are centered on health equity. That was an important part of the conversation. We were happy that that's reflected in those standards, including increasing payments for providers serving populations with higher health-related social needs. We really appreciate the emphasis on utilizing interdisciplinary clinical care teams to assess and address patients' medical, behavioral, social needs, while still highlighting the importance of primary care. Also importantly, recognizing the balance between getting data and information and not wanting to increase the administrative burden on our already kind of overly administratively burdened clinicians so that they can concentrate on patient care. And I think that these standards do a pretty good job of keeping that balance. We really appreciate the opportunity to engage on these issues, and while recognizing there may be some refinement that's necessary, it's a really exciting time for all Californians who will greatly benefit from a change in the system that puts more of a priority on primary care. So thank you very much.
Thank you. Looking virtually, Travis, go ahead.
Thank you. Travis West, Regulatory Policy Specialist with California Nurses Association, representing more than 100,000 registered nurses across California. First off, thank you to the OCA board and staff for your continued work on these difficult, very difficult and important issues. As was mentioned in the board discussion today, CNA remains concerned that the APM draft standards lack sufficient safeguards against unintended consequences of APM models, such as risk-based payment models that may incentivize cost cutting through the commoditization of care and place economic motivations and statistical performance above the best interests of each individual patient. Risk-based models inherently force providers to weigh care that could save lives and prevent higher costs in the future against the impact that providing such care will have on their bottom lines. It is therefore crucial that OCA do everything possible to ensure that this primary concern of doctors and providers in clinical decision-making always remains the well-being of the patient, and ensure that the consideration of cost does not incentivize providers to avoid or deny appropriate and necessary care. It's equally crucial that the adoption of APM standards do not further advantage large providers who can easily meet reporting obligations and gain performance and quality measures with the help of things like expensive algorithms and outside consultants at the expense of smaller providers who often struggle with the additional administrative burden of meeting reporting obligations. These types of unintended consequences can only be prevented if there are regulatory structures and guidance in place to identify and correct them when they occur. OCA should therefore consider adding additional language to the APM model standard related to monitoring for and preventing potential unintended consequences of APM systems, such as incentivizing avoidance of appropriate care or unfairly benefiting larger providers. We also encourage OCA to consider non-risk-based payments, including global budget arrangements, as set forth in the single payer proposals, such as CalCare. Thank you so much.
Thank you. Seeing no additional hands raised virtually and no one at the podium, that concludes public comment on this item.
Okay, first, as expected, rich public comment, very helpful and useful to think through. Appreciate the board's deep engagement. I think it was acknowledged by both the team and the public comment, but mainly want to thank the board again. I know a year of work. It's easy to come into these meetings and suggest some other things, understanding that it's not going to be easy to deliver in a month on everything. Please do what you can. We're looking forward to further digging in next month and seeing if there's enough satisfaction by the board to move something forward. I expect there will be. So appreciate the importance of the conversation today. Okay, with that, Sandra, see what happens when we switch chairs. You were 3 minutes early and I'm like 20 minutes late. So yeah, let's do a 30-minute lunch break, come back, and we'll dig into primary care. Thank you. All right, everyone, thank you. Could we reestablish quorum and make sure, while we're doing that in the room, we'll make sure we still have Rick with us online.
Yes, Dr. Mark Alley.
Present.
Dr. David Carlo.
Present.
Dr. Sandra Hernandez.
Here.
Richard Kroenig.
Virtually present.
Virtually present.
Ian Lewis.
Present.
Elizabeth Mitchell. Here. Dr. Richard Pan.
Present.
Don Molds. Don Molds is present, if that wasn't heard in the microphone. Thank you.
Okay, just for everyone following, we have a few things on the posted agenda, but I understand it's been clarified. We only really have one agenda item left, and that's around the primary care spending definition and benchmark. So turn it back to Margareta. But this is not a voting item today, so we can certainly continue to provide, just like we did on the last item, lots of good feedback, and look forward to the public comment on this one as well. Go ahead, Margareta.
Great, thank you. So we'll present today our draft primary care spending definition and investment benchmark, including a summary of the advisory committee feedback we received on our proposal in March. And again, I have our team member Vinayak Sinha from Friedman Healthcare, who's joining to help answer questions from the board. So to start, just wanted to share a timeline for finalizing our primary care recommendations. So as I noted during the APM workstream, we've been meeting monthly with our investment and payment work group since June of 2023, and we've really focused on primary care for about the last 6 months in addition to APMs. We also convened a technical subgroup of the work group members to inform the development of our primary care definition. So this month in the work group, we revised our primary care definitions and benchmark. We reviewed our revised recommendations, also reviewed them with the advisory committee. And we also released the primary care benchmark recommendation for public comment during the April board meeting, and we're seeking public comment on these recommendations until March 31st. So we'll share the feedback we collect today with the work group before coming back to you all in June, and then we plan to present a final benchmark for approval in July. We also have statutory flexibility on the timeline here, so if we needed to go beyond July, we could. And of course, we'll revise based on any feedback we receive from public comment and in between those meetings. So just a brief reminder of our statutory language that guides our work. So it requires OCA to measure the percentage of total healthcare spending allocated to primary care and set spending benchmarks for primary care that recognize historical underfunding of primary care services. It also notes that measuring primary care spending must consider categories of providers, procedure codes, and claims and non-claims payments. It also directs OCA to work towards building a system that reallocates resources from specialty care investments to primary care and behavioral health services, and focuses on recommending improved outcomes for primary care, like increased use of advanced primary care models, integration of primary care with behavioral health, and adoption of alternative payment models to support primary care. So these are all policy goals we've kept in mind as we developed our proposed definition and benchmark. And then the statutory language also requires that the board approve the primary care investment benchmark. So we look forward to your feedback today on the benchmark. And I'm sure I don't need to re-emphasize this with this group, but just to ground us in some background about why we're focusing on primary care. We know that a high-functioning healthcare system requires a foundation of high-quality primary care. A landmark 2021 consensus study by the National Academies of Science, Engineering, and Medicine published found that an increased supply of primary care services leads to more equitable outcomes and improved population health. And then also in 2020, a national study found primary care investment was about 6.3% of total spending across all payers, compared to 4.6% nationally. And that primary care investment nationally tends to range from 4 to 7%, according to this study, compared to other high-income countries, high-performing healthcare systems in countries where their spend tends to be 12 to 15% on primary care as a percent of total. And here, again, just wanted to emphasize some of the impacts of investing in primary care. So statute envisions that increased support for primary care will not increase costs to consumers or increase total cost of care, but rather that shifting resources away from specialty care or unnecessary care to primary care supports improvement. And our theory of change here is that increased investment in primary care in ways that reduce low-value care and waste, and then we can reinvest those savings into primary care. And in recent years, studies have shown that more primary care is associated with less low-value care, fewer emergency department visits and avoidable hospitalizations, better quality, and lower spending. So a robust system of primary care and preventive care keeps people healthy, reduces unnecessary and low-value care, and is really critical to a sustainable healthcare system. And to inform our work, the Investment and Payment Work Group essentially adopted a vision of primary care that was developed by the California Quality Collaborative. So we used this vision along with the statute to serve as a guidepost as we developed the primary care definition and investment benchmark with our work group. And the work group really emphasized that a sustainable and well-resourced primary care is needed to achieve the vision. So now I'll review our draft primary care spending measurement definition and methodology. And just as a reminder, again, as we talked about with alternative payment models, when we are measuring primary care spending at this point, we are measuring the dollars that payers send to providers or provider organizations in support of primary care services. And that Payers, not providers, submit the spending data to OCA currently, but payers may not know exactly how providers are distributing those dollars within their organizations, or exactly how much provider organizations spend on delivering primary care. And then in terms of measuring primary care spending as a % of total spending, this is the basic formula that we're looking at. So, you know, the numerator is primary care spend, so claims and non-claims payments, and the denominator is the total cost of care, which also includes claims and non-claims spend. And of course, we'll focus on the numerator today and how we are defining that. So again, just to emphasize a bit more on the data sources and how we'll be collecting and measuring primary care spend. So we will measure primary care spending by payers as part of our larger total healthcare expenditure data collection efforts and the data submission by payers for those efforts. Currently, we're not collecting data from provider organizations, but as we mentioned previously, we are looking to next turn to how to collect data from restricted Knox-Keene plans and limited Knox-Keene license plans. And then also wanted to emphasize here, same as the alternative payment model work, the non-claims payments will be categorized using HCI's expanded framework, which is in your appendix and we reviewed in the February board meeting and is also linked on our slide. And we'll talk more about the expanded framework in a few minutes as we discuss how to allocate a portion of primary care from non-claim, or how to allocate non-claims payments to primary care. And of course, we will provide detailed definitions, technical specifications, and technical assistance to data submitters for allocating payments to primary care. So for the purposes of measuring primary care spend, primary care is typically defined as when a primary care provider performs a primary care service, and definitions sometimes also restrict by the place of service or the care setting. So this slide shows the types of providers, services, and places of service that are commonly included in primary care spending definitions. And in our work with the work group, we explored how states and national organizations defined primary care and then adjusted to reflect the guidance and statute, the vision for primary care, our work group's feedback, and also advisory group feedback. So we are proposing a modular definition of primary care with 3 modules. So primary care paid via claims, primary care paid via non-claims, and then behavioral health delivered in primary care. And the modules allow us to track the different components of primary care spending, and all 3 modules would be included in the primary care investment benchmark calculation. And the behavioral health in primary care module could be added to the behavioral health or the primary care investment calculations. And now we'll move to discussing our specific recommendations for defining claims-based primary care spend. So this slide provides an overview of our approach to measuring primary care investment paid via claims. So we plan to include claims-based spending when a primary care provider provides a primary care service in a primary care setting. So all 3 of those components must be met for the spending to count towards the investment benchmark. And for providers, we plan to include a broad set of providers to reflect the statutory goal of promoting team-based care. And the investment, and also of note here, the investment and payment work group, the advisory committee, sibling departments, and stakeholders really discussed at length the potential to include or exclude OBGYNs in this set of providers. And at this time, we're recommending excluding them to align with the vision for comprehensive whole person primary care. And the predominant feedback we received from all of those groups and stakeholders supported excluding OBGYNs as providers in our definition. Although I do want to note we did receive some feedback strongly supporting including as well. And then for setting or place of service, here we exclude certain settings such as inpatient and retail clinics or urgent care sites to again reflect the work group's vision of promoting continuous coordinated primary care. And then for services, we propose an expanded set of services to encourage as much care as possible and appropriate to be delivered in a primary care setting. And this includes a limited set of behavioral health services when provided by a primary care provider. And then just a bit more on the non-claims payments approach. So starting to move into non-claims. So as I noted a few times, OCA in partnership across HCI, especially with our HBD colleagues, has worked with our consultants, Friedman Healthcare, to develop the expanded non-claims payment framework. And the framework provides a single approach to collecting non-claims payments across HCI. And we just wanted to share that this framework has been elevated to national discussions on collecting non-claims data and has since been incorporated into the National Association of Health Data Organizations Common Data Layout to support non-claims data collection by all payer claims databases. So using the expanded framework as our foundation for collecting non-claims data, we then look to see how to portion payments intended for primary care across each non-claims category. So we collaborated with payers and several workgroup members to develop a methodology to apportion shared savings and capitation arrangements to primary care. And then we reviewed these approaches with the work group, with our primary care technical subgroup, the advisory committee, and also sibling state departments. And I just want to emphasize that given the nature of non-claims payments, the payment measurement is less precise than claims-based measurement. And the proposed methods we will share today provide directional estimates of non-claims payments supporting primary care so we can better understand shifts in payments over time and make the best estimates that we can. And we are continuing to work with stakeholders to finalize our approaches here and look forward to your feedback as well. So in terms of the non-claims based primary care spending measurement approach, this slide provides a high-level overview of our proposed approach using, again, the expanded framework categories. So for category 1, which is population health and practice infrastructure payments, and category 2, performance payments, the proposed approach is the same. So all non-claims payments in these categories are allocated to primary care when paid in support of primary care programs. So examples of these programs include care management, care coordination, and population health programs, and performance incentives in recognition of quality outcomes attributed to primary care providers are also included. And we're proposing that payers would be required to limit the portion of practice transformation and IT infrastructure payments that count as primary care to 1% of total medical expense, which based on the 2021 commercial market data in California amounts to over $5 per member per month. And this approach is consistent with similar policies in other states that aim to recognize that these types of investments tend to have a broad impact beyond primary care and are not specific just to primary care. So we want to make sure that we're kind of accurately capturing and or trying to best estimate the percent that would go to primary care. And then for category 3, shared savings payments, here we're proposing to use essentially a formula. So the portion of the risk settlement payment allocated to primary care would be limited to the same portion that claims-based professional spending represents as a percent of claims-based professional spending and hospital spending combined. And then similarly for category 4, which are all types of capitation payments, global budget payments, fully integrated delivery system payments, the approach would depend on the type of capitation payment. So of course, for primary care capitation, 100% of those dollars would be allocated to primary care spend. And then for other capitation payments, like professional capitation, data submitters would calculate a ratio of fee-for-service equivalents for primary care services to fee-for-service equivalents for all services under the capitation. And then that ratio would be multiplied by the capitation payment amount. So again, just as a reminder that, the data we'll be getting on primary care spend initially will come from payers and not directly from provider organizations that ultimately decide how to allocate capitation dollars. So the formula intends to serve as the best estimate rather than a really precise measurement of capitation dollars spent on primary care. And we've worked with many payers to develop and vet this model. And just a note that these proposed approaches are detailed in the appendix. So now I want to open it up to any feedback on our proposed approach to claims-based primary care spend measurement and non-claims primary care spend measurement.
Go ahead, Richard.
Appreciate the presentation and the work that went in. It's just to understand, we have that slide with 3 circles. I don't go back to that one. Forward, 2 more, 1 more. The circles. Ah, there we go. Okay. All right. So basically, what you're saying is that we're going to have, and I realize these are not exactly the measures, because it sounds like you explained a little later. So you have to meet like all 3 in order to be counted as a primary care claim, correct?
Yes.
Okay. And the, and I guess one of the questions is, and again, I'm trying to think about how easy it is or hard it is to capture. Is there any measure of continuity, which would mean is that, and I know this is a little tricky because, you know, that, for example, you know, you have a one-time visit with one primary care provider, I guess primary care specialty type provider at a clinic, outpatient clinic that is for a, I don't know, ear infection, let's say. Would that count as primary care? That's not technically primary care. In the sense that how you describe what primary care should be about. It could be considered primary care service, but but it's would that claim be counted as primary care? So you saw one, let's say, family physician or pediatrician. They had one claim for ear infection that they saw in the clinic.
Yes, I think so, and would look, yes. So yes, that would count as primary care spend.
Okay.
Claims-based primary care spend. And then I think to the broader question of continuity, I think there are some ways we could use the HPD to maybe better understand continuity. I know Cover California is looking at a continuity of care measure that we are also starting to explore with them and learn more about how they're using that measure.
Yeah, so so that as a standalone to me isn't primary care, but it was connected to a series, another visit or a series like a health supervision visit, or would be. So I don't know if there's a way to capture that or not, because I think that this is back to the continuity part, right? So we have an episode, someone's seeing for one episode. I mean, that's an outpatient, but that's not what gets all the good stuff that you talked about earlier, right? And so this idea that you actually have a relationship with, it's not necessarily even just one person, it's a small enough group, right? That's the other problem. If you tie it to a big medical group, does that count, et cetera, versus, so I want to do a little thinking about that, because otherwise, if what we're going after, and frankly, for the big bang is actually for people with chronic conditions. So this is back to like, okay, where are we going to get, it's not about the individual ear infections, right? It's, if this is part of a pattern of someone who has a more chronic condition, ongoing chronic illness, or even something more significant, then that's where we're going to get all the wonderful things we want to talk about, right? So if someone has diabetes, but then it's that back to that relationship part. So do they have a relationship? Is it, if this is a one-off visit, and yes, sometimes we need one-off visits, but it's someone's putting all those pieces from these different visits, and they're all putting together the pattern, right? So you sort of collect it on the non-claim side, on the capitation, that's sort of at least hopefully inherent, right, in the capitation. So as you're trying to say what part of the capitation counts, et cetera, or what that, but on the claims side, I also wonder if there's a way to try to capture that piece about, is this part of a, a pattern or a set, right, with a group. So is this really relationship based? Is this, I assume that's sort of also the part about continuity, right? Is this versus, oh, we got a set of one-off visits, right? That really frankly isn't. And that's also why I think, and I believe it's excluded, you said urgent care, like, walk-in, stuff like that, right? Because that's not what's really going to give you the benefit, right? So I just want to think about, was there a way to capture that piece? Now, so there's put that idea. And then the other thing is, frankly, since you are sort of looking at all three, I might argue that OBGYN, I can see the argument to say why OBGYN, probably, there's a lot of OBGYN services that are not primary care, right? But there are some that, they do play a role, and in fact, and frankly, they're probably more likely to be primary care providers for women. And so excluding them altogether, I think still can be challenging. Now, if we're actually saying you have to intersect all three, I think you can exclude a lot of like the non-primary care stuff they do. Right. So I do wonder whether if we are actually saying not only it's that, we're not saying that everything an OBGYN does is primary care, but, and frankly, you know what, actually there was an article that came out stat, like for example, NPs and PAs, fewer than 50% of them actually provide primary care. Most of them are specialty services. Okay. So just, let's acknowledge that. That actually most PAs and NPs are actually providing specialty care. In the United States, only a minority of them are actually providing primary care. So it's not the provider alone. Certainly, there is a good portion who, of NPs, PAs, and including OBGYNs, and as well as that provide primary care. But that if if they're the provider, the place service, and the service itself is a primary care service, I think if you're going through all three filters, then probably you're still going to capture the primary care part of what the OBs are doing. And so I'm just concerned that by excluding them, we're actually excluding a set of providers who basically, first of all, disproportionately take care of women, and frankly, and so so I think we need to think that one through a bit more, and think about our attempt, as we say, you have to hit all three. Actually, we're going to actually capture that portion that they're doing primary care. Or we think we're going to be missing, or do you think you're going to be folding in too much other stuff?
Yes.
I mean, why?
From our discussions, that maybe not most, but a lot of OBGYN visits are coded as office visits, and if we exclude, we would essentially need to create a sub-definition for OBGYNs to even more narrow the set of services that count as primary care services provided by an OBGYN, and to essentially create multiple definitions.
So what kind of office visits are you thinking they're doing that don't fit under primary care? So let me just ask you a question then. Pregnancy services, outpatient, sort of managed during pregnancy, you consider that non-primary care or primary care, conceptually?
I think pregnancy services, if provided by a primary care provider, are included. By
an OBGYN. That's what I'm asking. Like, okay, you're coding, right? OBGYN, clinic, inter-practice, providing outpatient pregnancy, prenatal care. Do you consider that primary care or not?
No, pregnancy services are not included.
Okay.
Is that right?
See, I might argue differently, right? Now, so again, this is. I'm sure people will have different opinions.
I'll just double check.
Sure. Okay. All right. But because I do want to just think this through here. There are going to be, by the way, and I mean, there are going to be times when, again, I'm a primary care, pediatrician, general pediatrician. There are times when that a provider may take on a sort of primary care like role. And what I mean by that is actually assume care for the whole patient, right? Because there's some condition the patient has that's central to a lot of the other things. So pregnancy, frankly, I think sometimes oncologists, when someone's when they're not in remission, oftentimes take this role as well, where basically people go, you know what, that person has cancer. I don't know what to do if they have some other condition. So they actually take on. Now, again, this is a person in sort of the conceptual idea is a person who takes on that primary central role
and accepts responsibility for the total care of the patient. Now, they may make referrals. They're not saying like, I take care of everything. But I mean, that's essentially what we're trying to get at least in my mind, so that you have someone who's coordinating the care, who's actually assuming that responsibility and managing that. And so, I just, I want to think carefully about, and, OB in pregnancy is a pretty big chunk there, right? So I'm not sure it makes sense to exclude that. But I'd be curious what other people think of things.
Vinayak, did you want to address that question?
Sorry about that. Vinayak Sinha from Friedman Healthcare, senior consultant there supporting Margareta and her team. A little bit on those, for example, prenatal or pregnancy visits, pregnancy-related visits. Some of those services would be counted as part of primary care if provided by the primary care as defined in OCA's definition currently, which excludes OBGYNs. But those services would be those that are similar to what other primary care providers would be providing as part of regular E&M evaluation and management services. So not necessarily anything related more specifically to a delivery. And that's typically how OBGYN services not provided by an OBGYN are counted as part of a primary care definition.
So just to clarify, you said the delivery, all right? If I'm an internal medicine physician and I have a patient who's pregnant and I refer them, our family physician, right? There's a lot of FPs who don't do, right? Yeah, family. Well, the reason I picked internal medicine is because some FPs will manage the pregnancy themselves, okay, in some places, right? Right, okay, right, yeah. But what I mean is that whoever, right, internal medicine family practitioner who decide that they don't want to actually manage the pregnancy directly for whatever reason, right? And they refer to the OB, and the OB essentially during the pregnancy, because that's kind of like the main thing going on with the patient, decides to actually assume the central role until the delivery. That some people would view as, and a lot of it's preventative, a lot of it's, some people would view as them taking on a primary care role for that period of time. Are you saying that that's not, so if we exclude OB, then that means that gets excluded. So in other words, so is that what you're saying, that we should exclude that?
That's right. So if OBGYNs are not part of the primary care provider definition, when an OBGYN is providing those services, it would not be included.
Can I just follow up on that?
Yeah, I know there's a lot of interest on this one, Richard. I think you got us started. It's good. Can I just, before we jump in, Margareta, how much? This is a pause in the conversation. I want to make sure you get through it. This one's going to be an important piece of where we go. Can you tell me?
Yeah.
Do you feel like we should pause now? I'm happy to take your recommendation and finish this one up, or do you want to include it as part of the broader conversation that I know everybody is going to be interested to have?
I think it probably makes sense to wrap up the recommendations on the definition and then we'll move to.
Is that okay with the board? Well, okay, because this one, we're going to spend a good bit of time on this one, I'm sure. Okay, go ahead, Margareta. Continue, and then we'll have Sandra go next.
Oh, sorry, we can
you want to continue this
discussion.
discussion? I thought you wanted to get through your deck first. Okay, Sandra, in that case, go now.
Yeah, so I sort of had the reverse. A family practitioner who does family care, cares for mom and all the rest of the family, mom gets pregnant, those services would count as primary care if provided by a family practitioner, but would not be counted if provided by an OBGYN. Is that how this framework?
So yes, depending on the exact service, but generally yes.
So a family practitioner would count if they were managing prenatal activities with an individual. Those would count by that professional.
Mm-hmm.
That same service provided by an OBGYN would not?
Correct.
And I do want to note that we recognize this is a trade-off that we're making in terms of how do we, how do we think about primary care and, primary care providers, and really want to make sure that we focus on, providers that provide kind of whole person longitudinal care and care for all chronic conditions and things like that. So there's a gap we're missing potentially on OBGYN services and providers, but then it's also a consideration of how do we really emphasize the longitudinal relationship. So, when we took this to the advisory committee, many advisory committee members recommended excluding OBGYNs, and then several also in our work group recommend excluding for this kind of exact trade-off. And then but we of course also heard the opposite. So it's very much a trade-off and a challenging question.
Okay. I know, Rick,
Mark,
you.
could I just finish?
Yeah.
So that was on that piece. I love the framework, by the way. I think the framework is great. Appreciate all the work. The area that I wanted to get into a little bit more is how we think about behavioral health and behavioral health practitioners in this space. So we describe integrated behavioral health as counting as a service, but in provider types, we have less common behavioral health and similarly service codes behavioral health. And yet, from a whole person care point of view, I think we'd want to capture mental health, SUD, and all the other continuity of care issues. So how do we think about the provider types as it relates to trying to get behavioral health integrated into primary care?
Yeah, so we've included several kind of common behavioral health services in our services definition, and then also focus on primary care physicians, so family medicine, internal medicine, clinics, those types of providers in our provider definition. So we were aiming to capture maybe a narrow set of primary care, so primary care provided, or sorry, a narrow set of behavioral health services provided in a primary care setting. And since we'll also be measuring behavioral health spending, we have a kind of a broader look at behavioral health more broadly. So here we were looking to capture kind of more integrated or behavioral health services provided by a primary care provider. And then looking to use our behavioral health definition to think more broadly about either integrated behavioral health provided by different providers or behavioral health more broadly.
So I would just note that in general, primary care docs don't get great training in mental health or behavioral health. Just stipulate to that. We're working on that. That is a goal that we have, and we're making good progress, but in general, that is true. And so where we're getting good integrated primary care with behavioral health, by and large, we have psychologists and or psychiatrists that are working with us in those settings. That's also not yet at the level or quantity that we would like, but I think the concept here is whole person care, and that really is our opportunity to integrate mental health, substance use disorder with other primary care preventative activities and services. So just parsing through that, I look forward to the conversation on behavioral health, by the way, but I do think it's worth noting that these clinicians in general are not the clinicians that are delivering behavioral health, unless it's via telehealth, which I appreciate you including.
Thank you. Let's go to Rick, and then I'll come back to. Go ahead, Rick.
Thanks, Mark. Very narrow question. Internal medicine, is that meant to be general internal medicine, or does it include all internal medicine?
It is general internal medicine, adult, and geriatrics. I will say we have an additional step that we are proposing to use in our claims and in our definition of primary care is using or counting only claims or spending by these physicians, so family medicine, internal medicine, general practice, that are identified as primary care providers in a payers network. So we are looking to narrow down to those providers that practice primary care, or at least have said, in the network that they are available to practice primary care, because we do recognize that many internal medicine and or potentially general practice physicians have subspecialties and could practice under those subspecialties. So we're looking to try to be more specific in our definition by narrowing a bit to focus on primary care providers who have said in the network data that they are a primary care provider and willing to accept primary care patients.
Yeah, that makes sense, and it would be helpful, and it'd be helpful at least here to clarify that this is general internal medicine. You wouldn't want cardiologists who are doing evaluation and management visits to be counted as doing primary care, which it kind of reads here that they would.
Thank you, David.
Thank you. Another kind of very complex subject and topic. I probably couldn't even accurately describe the complexity. I mean, to your point, Rick, which is not what I wanted to cover, but for example, there are, say, cardiologists. I mean, every cardiologist starts out as a general internist, and they can do primary care before they do cardiology, and they can manage general internal medicine problems, maybe not as well as an entirely primary care general internist, but that just speaks to the complexity of it. I had two takeaways from the advisory committee on this topic. I think they really speak to again, the complexity and the importance of the discussion, and they focused on OBGYN and people. There was just a lot of, I thought there was a lot of discussion about the role of OBGYN in primary care. And I can recognize some of the complexities of the situation, recognizing that many people go to OBGYN providers really as their only source of care. I don't know necessarily how they would be described in provider panels, for example, but I think it is something that we might want to examine a little bit more carefully. Similarly, another topic that came up in the advisory committee was a discussion about non-claims payments in primary care. And it was noted, and I would tend to agree with this, that we're tending to engineer some proxies in the absence of good data or good methodology. And maybe that's the best we can do. And if it's the best that we can do, clearly we want to move forward. But let's recognize that this is more of a proxy approach than a direct measurement approach, which of course would be better if it was available.
Good points. Elizabeth.
Just very briefly, because there are a lot of doctors here that I will not second guess. I just want to weigh in that I think OBGYN inclusion is so important, particularly in rural areas where they may be the only source of care. So I just would weigh in that we need to figure out how to include them. And then I believe, mental health care is primary care. And so to be really thoughtful about inclusion of behavioral health providers as well.
Ian, next.
Thank you. Just on behavioral health care, I find myself ambivalent on this question. I mean, we want to be driving two things. One is promoting truly integrated behavioral health care and an overall investment in behavioral health care. And I'm concerned by by broadly capturing behavioral health within integrated behavioral health organizations or integrated healthcare organizations. We're capturing services that are being provided elsewhere, but for one set of organizations they're being captured in the numerator, and for another they're not. I take a lot of confidence in the fact that we have a separate work stream coming forward on behavioral health, and so I find myself slightly leaning towards relying on that, albeit if the family practitioners providing care, we should recognize that here in the numerator. I had a question on slide 84 on capitation payments, where data submitters, this is the last bullet, calculate the ratio. They, if I understand this correctly, they're essentially pricing the encounter data and then giving us a ratio.
is everybody going to be using the same methodology, or is it up to each plan to decide their methodology?
So we are recommending that every plan use the same formula. In terms of the formula that we've outlined here, it's also in your appendix. I think it's the very last slide on 154. But in terms of the fee-for-service equivalents, we are expecting that payers use their fee-for-service equivalents that are specific to their market and to them as a payer, so that it is most analogous to what they pay. So we are not proposing using like a standardized fee schedule. Unless a payer does not have a fee-for-service equivalent fee schedule, then we would use a standardized fee schedule.
But in this case, aren't we talking about capitated arrangements? So they're not actually reimbursing on that schedule, and so there's potentially wide variation. If one's using Medicare as a basis and somebody else is using a different, there could be really wide variation on how they come up with those.
We would expect, we'll be collecting the data by payer type and by market, so they should be using the fee-for-service equivalent that is applicable to that market.
Okay, I think I get it. Overall, I got to say, I think you've done a stellar job on this. So thank you.
Okay, I know you have more to present. Let's go through that. I'm going to hold my own comments and ask you all to do the same until we get Margarita through.
Okay. So that was our proposed definition, and appreciate all of the feedback there, and really looking forward to continuing to iterate on the definition. So here we'll just get into how we kind of some background data and some background on our decisions in terms of approaches to the setting a primary care benchmark. So this slide just summarizes some key decisions that we have proposed in terms of initial decisions, and then also preliminary recommendations here, and then also how other states have approached these questions. So this slide shows that states tend to make some of the same decisions when they are setting a primary care investment benchmark. So all states that have set a benchmark set a single benchmark across all ages and across and based on the benchmark, base the benchmark on a percent of primary care spending. And most states set an absolute benchmark and layer stair steps or relative improvement benchmarks along the way. And as shown here, OCA is recommending a similar approach. And note that the relative benchmark is an annual improvement over previous year performance, and that the absolute benchmark is a investment goal or investment benchmark for 2034. So to start, we just wanted to share examples from other states in terms of their work on primary care investment. So a few lessons learned. The first is that most successful efforts gradually reallocate spending to fund primary care investment, and that potentially, if the timeline is too condensed, efforts to increase investment may accelerate growth in the total cost of care. And 4 of the 6 states with investment requirements only focus on either commercial or Medicaid, and not both, nor Medicare Advantage. And these states have found that sustainable care delivery transformation requires multi-payer investment to give providers consistency in payment and expectations, and several of them are now working towards increased multi-payer alignment. And finally, other states' performance or efforts have taught us that increases in total cost of care can, of course, hinder success towards the primary care investment benchmark. So just as we continue, we wanted to discuss how and to emphasize how the statutory intent guides our work. So statute specifies that increased primary care investment should be a shift or a reallocation, not an increase in cost to consumers or total cost of care. And this slide shows an example of the math for that shift. So nationally and in California, hospital services generally make up a significant proportion of the healthcare dollar, and this national study puts them at about 38% in navy blue. Meanwhile, primary care sits at about to 7% of spending in green. So in this hypothetical example, if we shift 1% of total medical expense from hospital spending to primary care, it requires a small decrease in hospital spending, about 2.6%, and the resulting increase in primary care spending is significant, about 14 to 20%. So reductions in rates of avoidable emergency department use or avoidable hospitalizations are examples of low value care that can be addressed through greater investments in high value primary care. And reallocation of spending from low value or unnecessary care to primary care could of course come from other sectors, not just hospitals, just all with the goal of investing more in primary care and access to care. And then here on this slide, as with our kind of previous discussions with APMs, we're kind of aiming to balance the pace of change. So the states in this graph, Colorado, Delaware, Oregon, Rhode Island, and Connecticut, have the most experience working towards increasing primary care investment, and 4 of these states also have cost growth benchmarks. So states often aim to shift primary care spend by about 1% of total medical expense per year, but experience has shown that it can be difficult, especially when goals may be more dramatic. So the lesson learned from these other states highlight that increasing primary care investment can take time, and the states increasing primary care investment tends to track with those who really focus on increasing investment as a state. So here, Rhode Island has seen fairly steady increases in primary care spend since 2018. Oregon has seen overall growth since 2014, while Colorado has not seen much improvement. In Delaware, greater focus and a state requirement has led to more recent progress. And then on the other hand, in Connecticut, growth in total medical expense outpaced increases in primary care investment in the commercial market. So to preview, wanted to share our primary care investment benchmark recommendation, and then we'll walk through California data on primary care spend and then come back to our recommendation. So we are proposing an annual improvement benchmark. We previously referred to this in prior slides as a relative benchmark for payers to increase primary care spending by 0.5 to 1% per year, depending on their current level of investment, in addition to a statewide 2034 investment benchmark, which we formally labeled as an absolute benchmark, for California to allocate 15% of total medical expense to primary care across all payers and populations by 2034. So using this annual improvement benchmark is consistent with the approach from other states, as we showed earlier. And then also for the 2034 investment benchmark, the 15% number is slightly higher than the goals in other states. And this really is intended to reflect our care delivery goals, our delivery system structure, our younger population, and the time horizon out to 2034. So states with higher primary care investment have found or do spend less on avoidable hospitalizations and ED visits. And the 15% benchmark is also consistent, as I noted earlier, with high-performing health systems internationally. And the 2034 timeline, again, aligns with our recommendation for the APM adoption goals to really acknowledge the connection and relationship between the two, as APMs often support advanced primary care, and quality performance in APMs is frequently tied to primary care services. So in this slide and the next few slides, I wanted to share some data. So here we looked at primary care spending by commercial payer product type. This is data from the Integrated Healthcare Association from 2021 that shows primary care percent as a percent of total spending by plan product type in the commercial market. So of course you'll see that HMO plans tend to have a higher percent of primary care spend, around 9.2% on average, with PPO and EPO plans averaged about 6.3%, with both product types showing a range of investment across plans. And then here, this is a little bit more summary slide in terms of that shows primary care investment data from 2019 through 2021, again from the Integrated Healthcare Association. So the dark blue bar shows commercial populations combined. So you can see the primary care spend for the commercial adult population shown in light blue and pediatrics in royal blue varies significantly. So average adult spend was about 6.2 to 8.7% for adults, with pediatric spend was about 18.4 to 21%. And then for Medicare Advantage, shown in green, is fairly close to the combined commercial spend, which is about 7.3 to 9.9%. And this is data from a Medi-Cal study, Medi-Cal primary care spend study. And this notes that Medi-Cal health plans on average spent 11.3% on primary care services in 2018. And again, there's quite a bit of variation across populations, especially with the average spend in the pediatric primary care was about 28% compared to 11.6% for adults. And again, here and also with the IHA data, wanted to note that these reports use different methodologies than we are proposing today and different data sources. So we think, these are directionally helpful in terms of understanding current primary care spend, but we expect that our percent investment would likely, or our percent primary care spend calculated would likely be lower than some of these estimates using our proposed methodology. And then wanted to get into advisory committee and work group feedback on our recommendations. So we presented to the advisory committee a few times, and most recently last week. So first, several members supported the 15% benchmark. One noted that it was a nice runway, that it was aspirational but achievable. Members supported the logic behind the benchmark, to develop an aspirational benchmark that's based on both pediatric and adult populations across the state and creating a kind of combined benchmark for those populations. And the main feedback was that the 10-year time horizon was that care transformation takes time and that we should allow for that. So that's, has influenced our recommendation here on the 15% benchmark, which is higher than other states in the 10-year time horizon. And then one member on kind of the other end noted that the 10-year timeline is long and they would like to see most improvement happen in the first few years. And did want to note there that, of course, we will report annually in our annual report on improvement towards our annual improvement benchmark and the 2034 benchmark. And again, continuing with feedback from the advisory group, several members recommended separate adult and pediatric investment benchmarks to ensure adequate spending for both age groups. And they cited concerns about potential decreases or stagnation in pediatric primary care investment under a single benchmark. And based on our understanding of other states' experiences who use a single benchmark, no other state has reported decreased pediatric spend as a result of using a single benchmark. And also want to note that we can, using our claims-based definition, at least track claims-based primary care spending by pediatric versus adults. And also want to recognize the potential data submitter burden and also potential inaccuracies or in estimating primary care spend for non-claims payments or allocating primary care spend for non-claims payments into adult versus pediatric could be potentially inaccurate and challenging. Wanted to note here that also several members supported a single benchmark, appreciating the clarity of communication of a single goal. And then also wanted to note that we plan to, in our reporting, or we intend to in our reporting, include the plan's population age distribution to as context for their primary care spend. So recognizing that primary care spend for pediatrics should be more than the adult population, wanted to include that context. And then another area that was brought up by several members was that, again, going back to David's note about the formula to allocate a portion of capitation to primary care, that this would not capture all provider organizations spending in support of primary care, and one member recommended testing the formula with payers and providers, and we plan to do so. So we know that, you know, payers have potentially limited insight into how providers allocate funds within their provider organizations to primary care, and you know, we recognize that kind of no formula will accurately and precisely capture primary care spending at underneath a capitation formula. So we're aiming to kind of have a best estimate using the formula we proposed. And I think we have, sorry, maybe just a few more slides on advisory committee feedback. So again, similar to the APM conversation, several members suggested collecting data by provider organization to understand primary care spending by organization. And as we noted earlier, we do plan to collect data from provider organizations with restricted or limited Knox-Keene licenses in the future. And then several members noted that OCA should track complementary measures for primary care investment, like the PCP consumer relationship, continuity of care, and quality. And we're exploring additional analysis in HPD to better understand the connections between increased investment and these outcomes. So it's definitely something we are looking into to analyze in HPD or other ways. And then again, I'll pause here to see if Dr. Carlisle or Ian have anything to add on advisory committee feedback.
No, I think you summarized this great. The one other point I'd say, I think, related to the last bullet point is I had one advisory committee member join us, not just to track how increased investment in primary care leads to better outcomes, but specifically, is it resulting in reduced barriers to access in communities that have big barriers?
And I would agree also. I think if the discussion was there around the benchmark, it wasn't about kind of what it should be. It was maybe more how it could be measured and monitored. But I thought that there was a lot of consensus around the benchmark.
Great, thank you. So just a few more slides before opening it up for discussion. Just wanted to note, since there was a lot of consideration in terms of adult versus pediatric benchmarks potentially, or benchmarks by age group in the advisory committee, just wanted to share kind of our considerations for a single benchmark. So here we're really proposing to focus on annual improvement to monitor year-over-year increases in primary care spend leading up to that 2034 benchmark. And as I noted, we can collect and monitor claims-based pediatric and adult primary care spend. And then OCA and the HPD will continue to explore options for separating non-claims payments by age group and seek stakeholder feedback on that. So there's multiple layers potentially for separating out non-claims payments by both age group and then allocating to primary care. So we are proposing a single benchmark due to those kind of layers of complexity. And then also to emphasize here that we plan to report progress annually and will provide context with the population distribution by payer. And again, just wanted to share this slide of why we're thinking about aligned timelines, that really thinking that the alternative payment model work and the primary care investment work together to gradually reallocate investment towards primary care. And then I'll just leave it here with our side again on our proposed recommendation for an annual improvement benchmark and a 15% statewide benchmark by 2034.
Okay, I'm looking to the screen first. I don't see, Rick, your hand up, but put it up anytime you'd like. I know we've started a little bit of the conversation looking around. Who wants to jump in next? Elizabeth first and then Richard and then Sandra.
Thank you.
And Rick has his hand up as well.
Okay, thank you. First of all, this was a great presentation, a lot of information, very well summarized, so thank you. And I would also say we collect data on behalf of our members from commercial plans nationally on primary care spend, and actually it's slightly higher in California, unfortunately, not for lack of trying. My question was just around the, no surprise, the timeline. Who was suggesting that we take 10 years? Was it the primary care community?
So I think we've just generally discussed in our work group. I'm not sure if we heard any, I'm trying to remember exactly who suggested maybe the longer term framework, but I think in thinking about how much, especially lower plans that spend low, like in the 3 to 6% range, how much time it would take those plans to come up to 15%, and also how kind of in order to reallocate spending and not increase total spending, that will take a fair amount of care delivery transformation, which will take time. So those are some of the key considerations. And Vinayak, did you have others that you remember?
Sure, thanks, Margareta. I think one of the other pieces is we reviewed kind of what a 3% increase in TME based on the spending growth target would look like. And then as we reallocated potentially to increase 1% in primary care spend of TME, that would look like about a 17% increase in primary care spending overall, which would translate to about $9 per member per month, which I think folks realize would be quite an effort each year. And that's what would get us to that 15% along the 10 years.
Thanks. But one of the things that I think is called out very effectively here is that investment in primary care actually reduces total spend. And we've seen that in all of our work, even in California with small rural practices. So I would challenge the assumption that it will increase total spend. So just really curious about why the pace of investment.
I think it's the concern that without shifting spending, that if we just increased primary care spend without kind of gradually reallocating spending from other areas of the healthcare system, that would potentially increase total spending, and that it will take time to do that reallocation and restructuring our healthcare system to provide more access to primary care, to provide that kind of long-term preventive care that our healthcare system may not be structured in a way to provide, primary care access currently. So it was more about the long-term healthcare delivery system transformation that goes along with the reallocation of spending. And yeah, Vinayak, anything else?
Sure.
Others?
Thanks, Margareta. I think another piece that we do see is that increased investment in primary care does show a decrease in total cost of care over time. I think the key piece there is that time component and how long that might take. And so part of what more recent research does generally show is that we expect that decrease. It just may take some more time than as fast as the total cost of care may be increasing at a slower growth rate. So again, not to have an inflationary measure in terms of increasing primary care, but then also increasing total cost of care. So trying to provide that balance for reallocation.
I'm sorry, that just doesn't make much sense to me. I'm not challenging the point, but so perhaps if you put more into primary care faster, it might even accelerate the decrease in total cost of care.
And I think, correct me if I'm wrong, but part of the challenge is that if you're tying this back to spending growth targets, you're looking at 1-year increments, and the timeline for the return on investment in primary care is potentially outside of that. Is that the point that's being made here? So, pardon? Oh, sorry. Val. I think that's.
Except on the hospitalizations and ED usage.
So, it makes perfect sense that you'll see some return on investment within a year and some return on investment over a longer period of time. I can't speak to, but you probably can, to like the cadence of that and what falls within the year and what falls outside of the year, but some of it would presumably fall outside of the year. and depending on how much, it might have the same issue. I don't know.
We also have Mary Jo Condon on the line from Friedman. Mary Jo, do you want to weigh in here as
Sure.
well?
Yes, happy to. Good afternoon, everyone. Can you hear me okay, Margaretta?
Yes.
Okay, great. No, I think everyone is right. So primary care investment does decrease total cost of care. There is some research to suggest, I should say, that higher primary care investment results in lower total medical expense. It's also true that that rarely happens immediately. Those benefits take time to accrue. The benefits of building a relationship with a primary care provider, of getting access to people, of preventing hospitalizations and ED visits, none of those things happen overnight. And so as we look at states around the country that have the most success of increasing primary care investment in a sustainable way that does not increase short-term growth in total cost of care, it's a gradual reallocation of the healthcare dollar. And when we see what efforts have been most successful, if you look at places like Rhode Island that have had this in place for more than a decade, initially it was a 1 percentage point shift in that healthcare dollar each year. And then over time, building up to numbers like 10, 12, 15%, depending on what's appropriate for the state. And so that's sort of where we got these benchmarks from, was to look at a 0.5% to 1 percentage point a year, which, as Vinayak mentioned, is a much higher actual growth in primary care spending year over year. It's just that you're shifting 1% of the healthcare dollar, and then over time working towards a 15% total allocation.
Well, I definitely support the 15% threshold. I just don't see why we would wait.
Well, and there, just to raise it, and I think for future, all of this is for follow-up conversation a bit, but there's a lot of room between 1 year and 10 years is, I think, one of the points that Don, even in the, if we respect the foul 3 to 5 years, that's still not 10. I mean, it's worth some conversation on this point. Okay, who, I think Richard was going to go, and then Rick, and then we'll come back to Sandra.
Yeah, no, I appreciate the discussion, the presentation. I guess, well, as we look at that, you talked about Rhode Island, and your graph went from 5.7 to 12.3. So what exactly? Was there a concurrent reduction in hospitalization cost spending? I mean, what gave to? So in other words, where did you get the? Where did you spend less in? Since I guess Rhode Island's the one with the longest period of time here.
Margaretta, there's some research on that. Would you like me to share?
Yes, go ahead.
Sure. So there's a great piece actually that was written by Bruce Landon and some of his colleagues at the Harvard Medical School that looked at what sort of drove that shift. And in fact, it was a combination of things, but one thing stood out, and that was essentially primary care providers referring to less expensive hospital and other facilities, and then also just an overall decrease in those facility dollars. And so we can share that piece with the board, but it was found to be a decrease in hospital spending, inpatient, outpatient hospital spending, in part through better pricing.
Okay, so all right. Well, first of all, I'd be interested in seeing the paper. I was wondering really whether there was some transformation in the way they also delivered care, since we got more money going into primary care. I mean, it was just a matter of them changing the referral patterns. That to me, I have to admit, is not terribly impressive. You could do that without putting more money in, but if it's more of an issue of they actually transformed the way they delivered the care themselves, they were able to provide, I mean, that's what we usually expect from the data, at least from the the anticipation is that what would happen is that you'd have fewer preventable. It's not like I refer to different hospitals. Actually, you have fewer hospitalizations. Actually take care of more things in my own practice instead of referring. Actually preventing things from happening, ER visits, et cetera, that tend to run up costs because I catch them earlier. And also, and I know, we talked about definition. We're trying to limit the what you're counting in terms of infrastructure, EHR. I get the challenge about is that it's really for everybody, just for the primary care physician community. But I mean, you do have to think about part of it is, what kind of sort of infrastructure improvements, right? Are they bringing on? I mean, North Carolina's model or in Medicaid is that they actually gave them money to bring in to add professionals like nurses and so forth to do coordination of care, right? So you actually solve that more because they actually had people to do that, right? And so things like that is what I'm hoping you see with the increased primary care spend is that we're basically building the capacity of primary care to be able to take care of more things itself and not have to send it out.
Sure. So let me talk a little bit about sort of how that shift has happened in Rhode Island and also in other states. So as I mentioned, the immediate cost savings came from, as Dr. Landon's articles noted, some improvements in sort of referral patterns and also lower pricing and also I think some lower utilization. And we see that lower utilization also in other national work. So for example, there was the state level analysis that's referenced here on the slide that found that in general, states that had higher primary care spending had lower avoidable inpatient use, lower ED visits, et cetera. But I want to also talk for a minute to sort of the health system transformation that you referenced. One of the things that I think is so cool about when we do work in Rhode Island is we work often with a group called the Care Transformation Collaborative that is actually started along with this increase in spend. And what you hear around that table is really advanced primary care. It's primary care providers talking about, oh, well, my care manager reached out to this list of patients that had a gap in care. They just wrapped up a couple years ago a big project on integrated behavioral health. They're using these dollars to do the kind of care delivery that I think we all want to see in primary care. And it is exciting to see more and more of that happen in states that have had this type of investment for some time, but those types of workflow changes and systems changes just don't seem to happen overnight. They seem to take a little bit of time.
Well, if you read Don Berwick, which I'm sure you have, basically, he talked about you have to invest something first before the change, right? I mean, you got to invest so the change happens. When the change happens is when the savings. If the change doesn't happen because you didn't invest in it, you don't get the savings. So I think in terms of the pace, I hear what you're saying in terms of pacing, but one of the things I want to think about is instead of thinking of it as a linear line. I get it. You don't want to just dump a whole bunch of money at one time at the beginning, right? Because people actually may exceed people's capacity to invest, right? But I also think that there's a little more of a curve or an exponential growth that we can look at instead of a linear one in terms of building on that capacity to absorb and then make those investments. And as people are getting things going, that you are going to be able to accelerate the rate of change. So I certainly understand, it doesn't make sense just to simply dump a whole bunch of money up front because they may not be able to handle that. But what we do want to do is, first of all, give people assurance that they know the money's coming. So therefore, they're willing to make long-term investments, right? So what I want people to do is think about that, yes, there's a change, there's a commitment to this change, and therefore I'm going to go take the effort to do that. If they think it's going to be short term, this is always a challenge. We do the budget. Every time we give one-time money, people go, okay, I'll do a little bit. I don't want to get too stuck in the middle, right? If the money disappears. So if you know that's coming, that you're going to invest in that change, but also that can accelerate over time, actually. So it's not just a linear. You actually can do a little bit more of a curve. I think we hopefully can think about what that curve would look like instead of simply a straight line. Because I think if we want to try to get to that point as fast as possible, and I think many of us do, we want to think about what the pace of that could be in terms of investments, especially if there's assurance that there's some of the funds are coming. Now, the other thing I also want to make note is that, we're sort of setting a benchmark. That's kind of a very blunt instrument, a percentage number, right, et cetera. I hope that tied into that is an engagement of providers in primary care, right? Because they're the ones who know the best. I mean, we can do technical assistance, but it's the people on the front lines who know what they need, right? That I need to have a care coordinator. I don't have enough people on my staff. I need to, et cetera. And so that we're engaging them and giving them some ability to take the money and do what's what needs to be done with their expertise and knowing what needs to be done. So we can certainly tie it to certain benchmarks, but I hope that it's not simply plan, you need to bump your primary care, but there's not thought about, well, exactly how does that then get implemented? Again, back to the front line we talked about the last time. It's because in the end, what matters is how people change what they do at that patient care interface, right? And if it's all up here and it doesn't get all the way down there, we don't get the impact we want. So hopefully there is a thought about, as we're talking about, not just a benchmark percentage, but exact expectations of the plans and how they're engaging the primary care people they're contracting with in terms of, what they need to do, the kinds of changes and how they can spend the money, right? If it's sort of the same old thing, that may still lock them into not making the kind of transformations that we want to see that's going to lead to improvement. If there is more flexibility to say, look, there is accountability, but you can spend more on coordination care, other types of things, things maybe in terms of how they do the coding, or even if we're talking alternative payment models, exactly how you do a capitation or so forth, then I think we're going to see a faster evolution there. So hopefully that is part of this, not just a percentage, but engagement of the providers with an expectation of them having to report back what the impact is, but of giving them some flexibility to make the kind of changes they want to make that allows them to build that capacity to take more care of patients.
All right, thank you, Rick.
Thanks, Mark. Three sort of questions and comments, one of which builds on Richard's last comments. And it would be useful to know, and I don't know if this would come from Bruce Landon's piece or maybe more likely from the collaborative, Mary Jo, that you mentioned, to get a better understanding of what did change in primary care delivery in Rhode Island. I don't imagine the number of primary care physicians changed a lot, although maybe it changed a little. I don't imagine that their net income changed a lot, although maybe it changed a little. Maybe more likely is that, the sort of advanced primary care changed a fair amount, and that there are more care coordinators and nurse case managers and physician assistants and other folks. But do we know that? Can the care collaborative provide some information to support that, or does Bruce have any information? And then I think more relevantly, more relevance to our job going forward, what, if anything, will we know about California, other than that the investment, that the payments to primary care have increased? We'll know that from the payers, but will we know anything else about how the delivery system has changed? And I think it's important, this is a comment, to Margarita, I think, Margareta and others, to be thinking about putting in place, what do we want to know and how will we know it? Second, she said three, but there are four, I'm sorry. Second, very minor. Margareta, you said earlier that we would know from the payers how much was spent on primary care. I'm assuming that we'll know that at the medical group level. Is that a correct assumption?
No. Our data collection will be at the payer level to start, and then we, as we noted earlier, we do have the ability to collect data from restricted and limited Knox-Keene
I'm sorry,
providers.
can I interrupt? I wasn't thinking about the data from the providers, but from the payers, we're going to be getting the THCE data at the medical group level, whatever that appendix was of medical groups, which is constantly changing. Will we not be getting primary care data at that same level?
Yeah, that's We'll have to take that back, Rick. I think
Okay,
we have
well,
done some thinking on that. And unless Mary Jo, you're aware of other states tracking it at that level.
Yes, we do track it at that level in some other states. Provider group specific investment is tracked, for example, in Delaware. It's tracked mostly on a non-claims basis there. And you know, I think what you're saying, Vishal, is a good point, that we haven't yet decided at what level of granularity the primary care data would be collected. So, taking that back,
yeah.
but of course, appreciate your input.
I would strongly encourage us to think about collecting this at the medical group level. I mean, we're going to be trying to, Don Molds hasn't asked the same question he asked about the APM work, which is, we don't really have levers here, right? I mean, we can't make anybody put more money into primary care. We have the value of information and transparency. But if we know that, Blue Cross or Anthem has, 8% in primary care and Blue Shield has 6%, but we don't know that UCSD has X percent and Sharp has Y percent, that value of that information is going to be extremely limited in catalyzing change. I think it's very important to try to get this at the delivery system level and not just at, Anthem versus Blue Shield versus United. So I thought that was a throwaway question because I assumed the answer was, sure, we're going to be getting this at the delivery system level, but it sounds like that's not yet in the plans. I strongly encourage us to do that. Third, if we're going to be asked to vote on a 15% 2034 benchmark, it would be really, really helpful to have some estimate of what our current spending is when measured in the way that you're proposing to measure spending. And I heard from Margareta earlier, we probably don't know, there's uncertainty, and we've had a couple of numbers thrown around is pejorative, a couple of numbers provided about what our current primary care spend in California is, with the caveat that those numbers aren't based on the same methodology that we will be using. But, if we're asked to vote next month on, a 15% benchmark for 2034, it'd be really useful to have at least a kind of rough sense of what current primary care spending is when measured in the way that we will be measuring it. And then fourth, and last, I didn't quite follow the discussion about why primary care spending wouldn't be age adjusted. I mean, given the very large differences, and here I guess I'm more thinking of the delivery system approach again, but given the very large differences between pediatric and adult populations in primary care spending, and although you didn't present it, I imagine very large difference or pretty large differences between adult and elderly populations in primary care spending. It's pretty simple sort of technologically to do age-adjusted primary care spending. And I don't, seems like we should think about that, either at the payer level or the delivery system level, or maybe even, I mean, it's probably minor. I had this terrible fight last month when Mary Jo, you weren't here, and lost it about, age adjusting total spending. But, we are getting older. Maybe that has some effect on primary care spending, probably minor enough to ignore. But I mean, I heard Margareta talk about the difficulties of kind of getting this for non-claims based payment, but those difficulties are there for primary care spending, altogether. And we'll confront them and do the best we can. So I'd be interested to understand why don't think it's valuable or important to do some age adjustment on primary care spending.
Rick, I'll let Margaretta take this question, but then we could go back to your earlier question about the methodology.
Okay, thanks.
Sure. So we do plan on collecting and analyzing the claims-based primary care spend by age group. So we will collect that and report on that. I think the challenges, and Mary Jo and Vinayak, feel free to add, is essentially, if we take like the capitation formula we are proposing to use to allocate a percent of or a portion of capitation to primary care and try to use that same formula then to apply by age, it creates, additional layers of complexity. Also, not all non-claims payments are split by age group. They're intended to be population focused, or they're more, practice transformation payments or general payments to a practice. So trying to think about how to split all of the possible non-claims payments by age group, when they may not be, the purpose of them is not to split by age group initially, just creates complexities. But we can continue to take that back and look at if there are different ways we could think about splitting non-claims payments by age group. Vinayak or Mary Jo?
I might just give the example of like a shared savings payment. So you are a medical group, you receive a shared savings payment on behalf of a population. You likely care for kids and adults and older adults. And for good reason, you may end up spending more of that shared savings payment on strategies to improve care for older adults or for, those sort of in the rising risk category. That's often an effective approach. We couldn't know that, right? And so we wouldn't know how to divide those dollars up effectively across different age groups.
Right. I mean, if I can just follow up, I see that problem. What are we trying to get to here? We're not sanctioning anybody based on any of these numbers. There's no enforcement involved. We're trying to produce information that will be useful for the public and policymakers moving forward to assess primary care investment. And if we are comparing a delivery system that has a lot of pediatricians and a lot of kids with a delivery system that has a lot of old people and not very many kids, we strongly expect their primary care spending as a share of the total and also in absolute value to be different. And sort of acknowledging that and building something in on the front end to allow more useful comparisons seems like it would be helpful.
Just to add there, part of what Margaret would discuss was reporting on the age distribution of the plan as well with their primary care investment. So I think that'll help speak to the concern that you're raising a little bit as well.
I saw that, and it does help a little. It'd be helpful to go further to say, yeah, and the difference from the average age distribution would lead us to expect, X percent more or less primary care spending. I mean, most people aren't going to know what to make sense of a 2-year difference in the age distribution. So kind of teasing that out a little bit more would be helpful.
Michelle, before you come back, Richard, you wanted to say something
very,
to this item?
Yeah, very specific to this issue. I think some of the things as we're looking at, for example, compare pediatrics to adults and then talk about age adjustment. I think the other challenge is going to be, for example, as a pediatrician, we do have certain standards in terms of regular checkups. Now, not to say that all the teens show up. So so that might be a little different than, let's say, young adults or even middle-aged adults who may not. So I don't know if there's going to, when you say age adjusted, how smooth the age adjustment is, and exactly is it, it's not going to be a linear curve. It's, does it do this bump, right, et cetera. But I think the other interesting question, because we're looking as a percentage, right? And so in my mind, one of the challenges is going to be this, right? So someone who has a significant chronic illness, this probably is a percentage of primary care.
it's going to be smaller because they're going to require a lot more specialty care. Let's say versus someone who's healthy and actually may not need very much specialty care. Their primary care spend percentage will be fairly high, right? And of course, older people tend to have more chronic diseases, so there's that. But the real question to me then is not just the percentage, but for example, you could have someone who has a chronic disease where the primary care spend is actually higher absolute spend, but because they require a lot more specialty care, their primary care percentage is lower. But then you can have someone who's healthy whose primary care absolute spend is lower because they don't have many healthcare needs, but as a percentage of their spend is actually fairly high because they're not spending on very much else. And so I want us to think a little bit careful, and I think actually part of the reason the peds percentage is so high is not just because we're being very expensive as pediatricians. In fact, we're the lowest paid of all the specialties, but generally because kids are healthy and therefore most of their care is provided by what would probably be counted as primary care spend, right? But their total amount of spend actually is much lower because again, they don't have, they're generally healthy. But if you take a kid with a chronic disease, you're going to see. So I think we want to think carefully about the percentage part versus the absolute, right? Because what we want is that, again, it's not about driving up how much we're spending. I mean, we're at affordability, we're trying to get it down. But so when someone has a chronic condition, we do want them to have actually a higher absolute primary care spend, because hopefully that means they're getting better coordination, things that will decrease their overall spend. But as a percentage of the total spend, we're probably not going to be comparable to someone who actually is fairly healthy, right? And so forth. So I do want to think carefully about this absolute versus percentage, because we're up here and we're saying let's add a 15% for all the spending, but exactly how the operationalizes down to not just specific cases, but even classes of cases, right? So, for diabetes, what should be the right percentage for primary care spend? Probably higher, probably in terms of absolute higher than a healthy population, but probably as a percentage is still way lower because they have non-primary care, they have greater non-primary care needs. So trying to figure out how to balance all that, I think is going to be thinking about how do we be sure we land in the right place. And so I guess in terms of the age adjustment, you are going to, I think that the percentage is going to go down with someone who's older because generally they're going to have a higher burden of chronic conditions. But how do we take that number and make that meaningful from a policy point of view? Is a lower percentage, how much lower percentage is bad, right? Maybe the more of the appropriate question than just saying, oh, what's a lower percentage, and that in itself is bad. Does that make sense?
It does. David?
Sure. I think the office has done a great job with a very challenging topic, but in this case, actually, I think that the controversy quotient associated with it is pretty minimal. I haven't heard anyone that I can think of say that more primary care is a bad thing. I haven't even heard anyone say that 15%, roughly speaking, is a bad thing. I think there's a lot of consensus on both of these things. I think maybe the biggest challenge here might be question number 3, which is what the time frame is. And my sense is that we could probably be more optimistic or more aggressive with the time frame than a 10-year horizon. And I'm thinking just as an example or anecdote, this may be an Oshput example, and it predates my time at the office. But I think it was the Sam Brown program that created new funding for primary care residency programs. And then almost literally overnight, I'm a primary care general internist, many internal medicine residency programs became primary care internal medicine residency programs. They were doing the same thing, training the same people the same way, but now they were primary care. I don't think it'll be quite that easy here because we will need more to probably reorient the delivery system. But I think 10 years is a pretty long horizon for that kind of reorientation. I haven't heard any pushback against it, quite frankly.
Okay, thanks. Sandra, go ahead.
Yes, so I completely agree with Dr. Carlisle's assessment, both of where there's agreement and where we might want to push. And so in this question of the pace of change, I was sort of struck by your chart looking at the states and how they did this. Looks like Oregon did a pretty dramatic investment over a very short period of time. And I'm curious as to what the impact might have been on their total spend, as much as we've been following that. And I'm open to that answer for sure, but also just to say that there are many ways in which faster investment in primary care spend, to me, will accelerate the delivery system transformation we want. Keep in mind that at our last meeting, we had a lot of commentary about how fast we were imposing our total spend target. And we've made a decision about that in terms of how aggressive to be over a time period. And so my own sense, again, if you tell me that Oregon, blew through their spending target by fivefold, that'll be a different point of view. But in general, I think a 10-year for reaching this target seems longer than ideal. And clearly other states have invested more rapidly, and so I'd be interested in their experience.
Okay, just some, I don't want to say last comments, but I'm going to make some, picking up a little bit on what Richard and frankly Don mentioned. I think one of the missing pieces for me in this conversation is not just what's the goal in terms of percentage, how quickly, but frankly, what do we get out of it? And just my own experience working in two large parts of California as a primary care pediatrician managing large clinics and systems, the level of what primary care did in one of those cities versus the other was quite significant. And to your point, Richard, in one of those places, primary care depended on lots of specialty care to manage what I would say are bread and butter chronic disease primary care issues, where in another, it was quite the opposite. So understanding not just how quickly we get there or what percentage, but being really strategic around what we're looking for out of this investment. It's not just a shift in where we're spending the funding, but it has to be attached to quality. It has to be attached to satisfaction and equity as well. So I'm more interested to see how that plays into where we end up in the next meeting. And then I think I speak for the whole group to say, coming back to the question about OB, Guy, that we would like to see how appreciate the advisory group, everybody's feedback, that is maybe a provider type that doesn't easily get incorporated into our primary care calculation, but we're, I think, curious how it might be. If we were to say we want to see that built in, we'd love to see a recommendation or suggestion on how that happens. I'm looking around the room to make sure I'm representing the group's view. And as much as I'm interested in the same around behavioral health, I'm more interested in this iterative conversation to see what that separate conversation looks like on the behavioral health piece. And maybe we can return to this if that somehow doesn't capture it. So those are, I think, are some of my, I was hoping to wrap up, but let's keep going. Go ahead, Richard.
No, I appreciate that. And I'm not sure how to capture this, so sorry, I'm really speculating. But this idea, because we're talking about OB or other things, it's essentially, it's the, I guess, the physician or the group or the team that basically is accepting responsibility for the total care of the patient. Doesn't mean they're providing all the care, but they're basically saying, I'm going to accept responsibility to coordinate it, to make the referrals, to whatever else, but it all comes back to our team. And I'm not sure. So for example, if someone's pregnant and they have a family physician, and that family physician still says, I retain the rest, because yes, the OB is going to take care of the prenatal, but I'm going to take care of the rest of it, then the primary care would be the family physician. But if they're like, I'm going to pass it off to you until they deliver, or, it could be that someone says, that's the only physician I see. So that person is assuming that responsibility and is accepting it. So I think that's conceptually what we're trying to say. Someone who's the primary care is the group, is the team that's accepting that responsibility. How to capture that in a claims base is going to be a little more challenging, but hopefully maybe there's some thinking about that.
Yeah, I agree. Okay. Any last comments? I'll just say on behalf of the board again, terrific. I mean, not controversial, as David said, but still very complicated and lots of things to consider given the data sources we have for the information and what we're trying to achieve with this. So very much grateful for the hard work that went into this presentation and getting us here. Okay, so we are now going to move into two public comment periods. I think it is, let's keep them separate. One related to this agenda item, and then we will follow that up with general public comment as well. And I, for one, I'm not going to be able probably to stay till the very end of it all, but just want to, before we get into that, just preview a little bit about our next few meetings, the next quarter of meetings. We will plan to have a meeting next month. The current plan is to not have a meeting in July, and then the August meeting, we're hoping to have a bit of a road show that we threatened to have earlier, which is down in Monterey. So we look forward to inviting the board and the team, the staff, as well as the public to join us there in August, fingers crossed. But that's the next three meeting or the plan for the next 3 months. Okay, let's go ahead and open it up to public comment on this agenda item.
Great. Let's start with virtual attendees. Lisa, you are unmuted on our end. Please go ahead.
Hi, Lisa Fulberg, CEO of the California Academy of Family Physicians, mostly in support of the definition of primary care presented by staff and recommended by the Investment and Payment Work Group. Starting with the issue of OBGYNs, there is no doubt that OBGYNs provide essential services for many women, and during certain times during a woman's life, maybe the clinician they see the most. And it's clear OBGYNs provide some primary care services. I think whether they are included in this definition really depends on our goal, on your goal as the board. If the goal is measuring units of care provided, OBGYNs, and for that matter, cardiologists, dermatologists, any clinician providing a primary care service should be included. But if the goal is trying to get to a comprehensive, coordinated system of care that saves money and improves outcomes, we probably shouldn't include OBGYNs. OBGYNs, while they provide really essential services, are not splinting a finger or starting cholesterol medicine or doing a skin scan. And they generally don't coordinate or manage care across the healthcare system, including managing care for all the other body systems that a woman has. As a member of the payment and advisory subgroup, we had a really thoughtful discussion with most advisory group members supporting the exclusion of OBGYNs, and this was a discussion over a couple of different meetings. I know it has become a pretty political issue, but I want to go back to the data. And during those discussions, there really wasn't data provided to support the contention that OBGYNs provide comprehensive continuous primary care as defined. If that data is presented, the board should absolutely reconsider at that time, including OBGYNs, and make appropriate adjustments to the primary care spending benchmarks. Or if the goal is actually just to measure units of primary care provided, then OBGYNs should be included. If not, then they probably shouldn't be, as they don't meet that definition. One comment about Knox-Keene, which I know came up. Knox-Keene Act regulates health plans, and OBGYNs are included in that context as a primary care physician to ensure that women don't have plan barriers to access an OBGYN, something that we at the California Academy of Family Physicians absolutely support. That is really different than identifying what constitutes comprehensive primary care. The OCA definition of primary care clinicians will not limit a patient's choices or interfere with an established relationship with an OBGYN. Exclusion from that definition would just mean that healthcare costs for OBGYN services won't be counted as that sort of primary care spending. And if again, going back to the goal is truly to get a more coordinated system of care, then that measurement matters a lot.
3 minutes.
Lastly, we do have some hesitation about including pharmacists as PCPs as they don't provide comprehensive services. However, for the purposes of measuring primary care spend, inclusion is limited to the clinic or office setting, as I understand it, and doesn't include EM codes, which of course presume medical management. So we understand the logic that it may help with team-based care and may be important for the clinics, but I just wanted to note that we had some hesitance with including them. Thank you.
Thank you. To the individual at the podium.
Good afternoon, Bill Barcelona, America's Physician Groups. I just want to add some information to the discussion here at the board level about monitoring at the medical group level. I've been studying provider networks in California all the way back to 2001 during my career. We recently pulled down all of the DMHC filings on networks and had them put into a database. And DMHC tells us that they represent 96% of the market in California through their licensees. And what we found, which is kind of counterintuitive, is that in the health plan filings, you can identify 8,111 separate medical group entities in those networks that are filed through the DMHC. So it seems logical to measure primary care spend at the medical group level, at the provider level. I just want to caution you that it is very complex and difficult until you get to a protocol on how you want to identify what is a medical group. So you need to think about that as you move forward. Thank you.
Thank you. Looking virtually, Ryan, go ahead. Ryan Spencer, you're unmuted on our end. You might need to unmute on your end.
I apologize for that. Thank you. Ryan Spencer, advocate for the American College of OBGYNs, District 9. ACOG has serious concerns with the recommended definition of primary care provider that excludes OBGYNs. In fact, we were a little shocked by it. This recommendation ignores the facts and the value that OBGYNs provide as primary care providers. And we really appreciate all that was said by the board members, but also OBGYNs do provide whole person comprehensive care that addresses a wide range of health issues, not limited just to reproductive health. They manage both acute and chronic medical conditions, offering a holistic approach to women's health, cancer screenings, mental health screenings, vaccinations, the list goes on. For many individuals, as what was stated earlier, an OBGYN is the first and sometimes the only healthcare provider they consult for health issues. In fact, I understand there's some data that was submitted to DMHC that showed 9% of primary care providers reported by health plans were identified as having a specialist type of OBGYN. But 72% of those OBGYNs reported by health plans were identified as serving as primary care providers. Also, the Affordable Care Act defines patient-centered medical home and primary care residency programs as including obstetrics and gynecology practices and specifies health plans must allow direct access with no prior authorization to OBGYNs. In fact, many states, including California, as you know, and was mentioned with the previous speaker, they recognize in statute and regulations that OBGYNs provide primary care services. They help patients from adolescence to menopause and beyond, and it's continuous care over decades. It just seems nonsensical to now completely exclude OBGYNs, but as mentioned previously, include, say, pharmacists in the rationale of comprehensive whole person care. The reasons are frankly hard to decipher. OBGYNs are an integral part of providing primary care services to our population, and they should be included when determining primary care spend. Said differently, if excluded, we'd be excluding some primary care services for many women. With that, when the time comes, ACOG asks that you reject this recommendation and include OBGYNs as they should be. Thank you.
Thank you. To the individual at the podium.
Katie Bessler,
Salinas Valley Federation of Teachers. Thank you for that robust discussion. I would just like to mention that in Monterey County, urgent care centers offer primary care. And I know that in the presentation, one of the circles said not traditional, but in our list of primary cares, they are the physicians that work out of the urgent care centers owned by the hospitals or partially owned by the hospitals. I too support that OBGYN is primary care because personally that is who my primary care physician is. So thank you very much.
Thank you. Looking virtually to Stacy. Stacy, you're unmuted on our, go ahead.
Oh, there I am. Hi, good afternoon. I'm Stacy Widorf with Planned Parenthood Affiliates of California. PPAC represents California's 7 Planned Parenthood affiliates, collectively operating more than 110 health centers across the state and providing over 1.2 million annual patient visits, more than 1 million of which are provided to patients accessing care through a Medi-Cal program. While abortion, family planning, and STI care are core services at Planned Parenthood health centers, the 7 affiliates also provide an expanding range of additional services that better encompass their patients' needs, including non-specialty behavioral health care, gender-affirming care, and primary care. The health centers employ and contract with a variety of clinician types, including physicians, nurse practitioners, and physician assistants to provide this wide range of services, many of which are reflected in the proposed primary care spending measurement definition. PPAC appreciates and supports the office's work toward increasing investment in primary care and improving healthcare affordability. However, as was noted in our letter, PPAC has concerns with a few aspects of the proposed measurement methodology. First, we disagree with the recommendation to exclude primary care services when provided by obstetrician gynecologists in primary care settings from the measurement. Many of the physicians that provide patient care at the California Planned Parenthood health centers, and as was mentioned by some of the board members in a number of other primary care settings, are OBGYNs, and for many of Planned Parenthood's patients are their only regular providers of primary care. In instances like these, where OBGYNs are providing the exact same preventative services in the same settings as their colleagues, we urge that those services be counted in the primary care measurement. Additionally, PPAC asks that the board, in finalizing and adopting the methodology, clarify that family planning and contraceptive care is considered part of primary care services, and that it also ensure that all primary care clinics, and not just federally qualified health centers and rural health centers, are a part of the list of eligible primary care settings. I appreciate the opportunity to speak with you today and look forward to further discussion. Thank you.
Thank you. To the podium.
Beth Capel on behalf of Health Access California. That vision of coordinated primary care, anchoring the care that people get, is what's underpinning this discussion. Part of the challenge we face is that the data we're relying on is essentially what payers pay. And there's somewhat of a mismatch between some of the discussion here today and the data that we're relying on to measure this. But what has underpinned the recommendations that staff has made to you is moving California toward that vision of coordinated primary care as what a well-functioning health system does. So the measure of primary care spend is a somewhat crude measure compared to the vision that we have of where we're trying to go. On the other hand, given where we're starting from, we can make a lot of progress simply by improving spending. 2 additional points on the vision of coordinated care. Health Access has opposed the inclusion of retail clinics and urgent care centers as primary care providers because that's not a coordinated care setting. That's not part of what people, that kind of transformative primary care that's clinically effective. consumers don't go there because they prefer it. They go there because they have a lack of timely access to primary care. And we should be, part of the reason to improve the investment is to move to a world in which people have timely access to primary care, preferably from an ongoing team of providers. And that's part of what we're trying to move the whole systems toward. With respect to OBGYNs, the existing law, the Knox-Keene Act, defines primary care as providing care for the majority of healthcare problems, including but not limited to preventive, acute, and chronic. So if the OBGYN is screening for and managing asthma, diabetes, hypertension, depression, and is the person you call when you have COVID, then yes, they're a primary care doctor. If they're not, we would submit they're not. And so that's the challenge that you face in trying to make these discussions. And that's where why the work group ended up where it ended up. Thank you.
Thank you. Looking virtually, Bill Kramer, go ahead.
Thank you. I'm Bill Kramer. I'm Senior Policy Advisor at the Purchaser Business Group on Health. Wanted to offer some information that might be helpful to the board in its discussion about the pace of change in terms of moving toward 15% target of investment in primary care. Many of you may be familiar with the Practice Transformation Initiative that was led by the California Quality Collaborative in collaboration with IHA and the Center for Care Innovations from 2016 to 2019. In the PTI program, worked with 13 provider organizations across California, represented coverage for about 3 million patients, and covered all types of payers, commercial, Medicare, and Medicaid. The results of this were pretty dramatic. In particular, there were significant reductions in hospital utilization as well as emergency department visits. And those improvements took place in the first year. And by and large, those improvements were sustained, especially for hospital utilization, a little less so for ED visits. But I think this could help inform the board, particularly referring to discussion that you all had earlier regarding the necessary investment, yes, and how quickly those investments would pay off. The PTI experience seems to indicate that those investments can pay off fairly quickly and help the state achieve its overall cost growth targets over the next several years. So I hope that's helpful. We would be happy to share that information. The full report was published several years ago, and of course is available to the public and to all of you. It may be helpful. Hope this is informative and as you debate these issues.
Thank you. To the podium.
Janice Rocco on behalf of the California Medical Association. I think we've had a very good discussion this afternoon, including, obviously, we're strongly supportive of increasing spending in the primary care space. As a member of the work group, I am one of several members of the work group who repeatedly told the OCA staff that we opposed the recommendation to exclude primary care provided by OBGYNs. It was by no means a strong recommendation coming out of that committee for one side or the other. And I think that we really need to think about the statute, which I tried to bring folks back to many times during the work group meeting. And some of the response I got was the statute doesn't matter. The U.S. Preventative Services Task Force recognizes OBGYNs are primary care providers. The statute, whether you're looking at the Knox-Keene Act or the Welfare and Institutions Code or the Insurance Code, recognizes that OBGYNs are primary care physicians. The state provider directories list OBGYNs as PCPs. And so we shouldn't be in a position of having this body erase some of the primary care spending from the total cost of healthcare expenditures in the state. We need to actually have an accurate representation of primary care. The staff recommendation deviates from the statute and from the implementation of the law by other departments within HHS, and we would strongly urge you to accurately count the total healthcare expenditures of primary care by including primary care of patients who've chosen an OBGYN as their primary care provider, as the statute allows them to do. Thank you.
Thank you. Looking back virtually, Mohit, go ahead.
Coach with Anthem and Elevance. I'd like to really echo some of the comments we just heard from the CMA. There are many ways that people get primary care. One of the issues in California, quite frankly, is that not everybody has access to a PCP in their neighborhood. Therefore, they might go to urgent care and get the services needed. We've even heard cases, and this is unfortunate, where you have people who call their PCP office to get in and are told, hey, if you have an urgent care closer, we can't get you in for 2 days, just go get the service that you need. So when we're trying to set a baseline, and this goes back to the advisory group discussions that we've had, I don't believe in any way that there was any kind of unanimity in recommending what's before the board today. In fact, in written comments, we have submitted very clearly that there are several facets of primary care spend that simply are not being included to create a realistic, believable baseline for spend in the state of California. I completely agree with the aspirational aspects of what we are trying to achieve, which is teams-based primary care and a medical home. We are all striving for that. But without creating a baseline that is realistic, you have nothing to measure against, number one. Number two, leaving out items like were just brought up by Planned Parenthood, contraceptives, the cost of those drugs, the cost of vaccinations, how those are administered and paid for within a primary care setting, leaving those types of expenditures out also does not constitute a full picture of what we are trying to measure in terms of primary care services. One of the major recommendations we made in our written comments was to specifically say, okay, we have a set definition. We want to get to this concept of teams-based primary care that is comprehensive and creates a medical home. Fine, that's great. But what you also have to do is illuminate all of the expenditures you are not including. So if there is going to be public reporting, and if health plans and providers and others are all going to be held to a set of standards, I would submit to you that publish your definition, but at the same time, be very clear about what you are not including, which others might consider primary care. And I completely appreciate the discussion around the ACOG issues in general, as well as the work that we are fundamentally doing with everyone around the table, including PBGH and others. We want to get to better primary care in every way we can, but we cannot do that if we start with a false baseline.
Thank you. Looking to individuals at the podium, if you'd like to make comment, please do so now. That concludes public comment on this agenda item. Moving to general public comment.
Dr. Pam.
I know we're not responding to public comment. This is not a response to public comment, but I know that in some of our presentations, people refer to research studies or articles. Is there a way we can get copies of them if they can give you the references? I would appreciate that. Thank you.
Yes, we could share that.
Great. So let's open it up for general open comment on any item before us as a board. Oh, sorry. Elizabeth?
This is for a future item, if that's okay.
Please.
Since our last meeting, we've gotten some feedback from the industry, and we were told in a meeting that even if they reduce their costs, that doesn't mean that would translate into lower premiums for anyone. So I guess one of my questions to this body is there a way to monitor that? Sort of how does any cost reduction then get reflected in rates to consumers?
Michelle.
Yeah, we could address that next time. There there is something in the statute to create a feedback loop with DMHC and CDI, and we could circle back on that.
Just to say, we do plan for that to be part of the reporting. So just as we're measuring spend over time, we'll also be looking at consumer spending, including premiums.
Anything else from the board? Okay, open comment on any item, please.
Hi, Ivana Krajinovic, Unite Here Health. I just wanted to mention that RAND has come out with its fifth round of prices paid to hospitals by private health plans. This is really critical data that pulls together, that RAND does a really nice job pulling together, and it's data mandated by transparency regulations. This was the data that first allowed us to identify Monterey as an area of concern for us. And the numbers continue to be really shocking. In 2022, which is the data from this round, the national average for inpatient pricing as a percentage of Medicare was 254%, which is up quite a bit from 2020 when it was 224%. In California, it's even higher at 282%. Taking a look at Monterey County, Salinas Valley Hospital is at 356% of Medicare, Natividad at 454% as the number 2 highest hospital in the state of California as a percentage of Medicare, and at number 1 in the state is the Community Hospital of the Monterey Peninsula at a whopping 540% of Medicare. The other interesting thing that RAND notes is that, and I'm going to quote here, very little variation in prices is explained by each hospital's share of patients covered by Medicare or Medicaid. A larger portion of price variation is explained by hospital market power. This directly refutes the testimony we've heard from CHOMP and Salinas Valley that it's all about payer mix. It's not about payer mix. They charge more because they can, and Monterey County residents don't have any choice. We are thrilled that the board is considering coming to Monterey and having a more robust discussion, and we really encourage you to, hopefully employ some of these third parties that can help shine more light on what's going on in Monterey. The work that OCA is doing is so important, but it's not going to be really meaningful in Monterey if the base level of prices continues to be so high. Thank you.
Thank you. Looking virtually, seeing no hands raised, looking to the room. If you'd like to make a comment, please step to the podium.
Hello again, everybody. Kevin Kazi, I'm the Chief Development Officer at Montesh Health. We heartily dispute those RAND numbers, and we're thrilled you're coming down in August. We will happily host you at the hospital. You can meet with our CEO, our CFO, any other clinical leaders you want. We will open up and share all the numbers you need. Happily, we're willing to do it. And to articulate the level of care that we give, the propensity of care that we extend into every corner of the county. So much of that care is free to the public and free to those who need that help. So I brought a bunch of folks to tell you how proud they are of where they work and how we do the work that we do. I'll spare them that since you're coming down. We would rather just get into depth with you directly there. Happy to do it. I'll personally coordinate any of the details in order to do it. So thanks for the time. We welcome it. We really do. Thanks.
Thank you. Seeing no virtual hands, going back to the podium.
Members of the board, staff, thank you for your work. It's been a long day. Almost out of here. I won't keep you more than 2 minutes more. We'll also be happy to host you. I'm president of MixSig, a JPA that provides health benefits to public employees throughout Monterey County and somewhat beyond. I'm also a labor leader in Monterey County and across the state with California Federation of Teachers, a union of educators and classified professionals. 2 data points to share. Currently, the cost of the PPO 25 family plan in MixSig is $41,000 a year and change. And currently, the PPO Select family plan is $22,500 a year in change. The reason for the differential, there's only one, it's the same ASO. The only difference is the PPO Select Family Plan restricts folks from going to Monterey County hospital providers. That's the only difference. Half the cost. And for projected rates at 16%, as I shared with you last month, that means the family plan for PPO 25 will be $6,600 more a year. And for the PPO Select plan, be about $3,600 more a year. The PPO Select plan will have to take a hit because of the other plans that use the hospitals in Monterey County to help fund that. You'll note that both those increases dollars were more than $1,000 that Montage is giving to the teachers only of Monterey County and not the rest of the commercial insurance payers and workers throughout Monterey County. Maybe they got some more money to cough up with that $1 billion reserve. Well, minus 0.5%, of course.
2 minutes.
So far. Thank you for your time.
Thank you. Looking virtually, seeing no hands raised, going back to the podium.
Good afternoon, everybody. Cesar Lara with the California Labor Federation, and I do live in Monterey County, and really encourage that you guys will come visit us in a couple months, and also want to make sure that it's not lost that Monterey County is not the only county in this unique position because of other costs, but Monterey County is a good example of a system that, you know, residents are held hostage with high cost of hospitals, and really happy to hear that Trump is willing to host it with their $1 billion plus in reserves. They could probably show you a very good visit down there. But, you know, really want to thank the board for making the tough decisions with at the last meeting, and understanding that there's still hard work ahead of us. So thank you.
Thank you. Looking virtually, seeing no hands raised, noting we have 61 attendees, going back to the individual at the podium.
Hi, everybody. My name is Greg Smorzewski. I'm with Montage Health. I am one of the vice presidents and chief human resources officer. I'd like to start just each of the individuals in the room that just came and spoke. We are currently negotiating in good faith with each of them, and hope to come up with some solutions in the future. Look, I came to Monterey 10 years ago, moved here from San Diego, have 4 children, wife, love the place. It's an amazing place to raise our family and to work. By far and large, our largest expense and the primary driver of costs are our dedicated staff. In a small and exceedingly expensive place to live, recruiting and talent remains our top priorities. We've tackled this head on by focusing on compensation, benefits, and enabling our staff to reach their highest level of potential within our organization. So if we want to talk about pay scales, we understand the importance of offering salaries that meet industry standards. We pay at the 75th percentile. That's so that we can keep our people and provide excellent care to the folks in Monterey County. Not only are we providing good pay, we're providing good benefits. We recognize the importance of retirement plans and benefits aimed at safeguarding people's physical, emotional, financial health for their staff and for the families. We have a small community of workers in Monterey County. There aren't a lot of folks who actually work. There's a lot of folks who are retired. We employ over 3,000 of those individuals. They're part of our community. They're our family. They're our friends. Additionally, we're invested in just the absolute growth of the folks. We provide a lot of our resources, a lot of our money, over $15 million a year
2 minutes.
to our professional development and our continuing education. I'm not going to take any more time. I thank you for listening. We do a great job of taking care of our community, and we're proud of that fact. I'm happy to be up here speaking about it. So have a good day.
Thank you. Looking virtually, seeing no hands raised, looking to the room, seeing no one at the podium, that concludes general public comment.
Great. Unless there's anything else from the board, we will stand adjourned. Thank you to the staff for all the amazing work and preparation for today's meeting. I appreciate it. Thank you. Bye-bye.
All right, thank you.